Good morning, everyone. On behalf of WHO SEARO, I welcome you to second day of the Southeast Asian Informal Regional Consultation for implementing Global Patient Safety Action Plan 2021-2030. 2 days Southeast Asian Regional Consultation for implementing GPSAP is being held virtually from 25th to 26th April 2022. Day one of the consultation discussed WHO spearheading global patient safety initiative through adopting World Health Assembly resolutions on patient safety related topics. The regional strategy for patient safety 2016-2025, an overview of global patient safety action plan 2021-2030, and developing patient safety strategy, policy, legislative and institutional framework. It was followed by a roundtable discussion on the status of patient safety at country level, including best practices, gaps, and challenges from the respective countries' representatives and the technical support required for implementing the patient safety action plan. Member states are in different stages of implementation of regional strategy for patient safety. It was recognized that it is important to have a national patient safety policy, strategy, and implementation plan with regular monitoring and evaluation. It is important to have high level commitment to ensure annual allocation of funds to the program and a coordinating body to implement the program with regulations in place. An integrated approach to this cross cutting multidisciplinary area of work is important to avoid duplication of efforts and thinning of resources. It is important to constitute committees with involvement of various stakeholders. Importance of accreditation of healthcare facilities, minimum criteria for each level of healthcare facilities, regional patient safety network, and patients' families for patient safety were highlighted. Safety of healthcare workers, proper environment, good infrastructure, qualification and an adequate number of healthcare workers, non-punitive approach to ensure incident reporting, proper data collection and analysis to produce evidence-based documents were the topics raised by most of the member states. So this is in brief about the last one day, that is 25th of April. With this, I would like to hand over the floor to Neelam, who will be moderating the session. Over to you, Neelam.
Good morning, colleagues, and thank you very much, Aparna. I must say that reflecting on yesterday's proceedings, I was really delighted to see the depth of discussions and the issues which were discussed. It was really enlightening for all of us. And we are definitely enriched with the exchange of information and wisdom which happened yesterday in this meeting. And I hope that we could continue the same and we could come out with some very concrete recommendations and next steps on how do we take forward the Global Patient Safety Action Plan and the regional strategy and to their full implementation over a period of 10 years and one focused on to the priorities for next 2 years. So we are starting this session now on some of the key initiatives of WHO. As you know that as part of the Global Patient Safety Action Plan under the 7 strategic objectives, they are very concrete systems approach to patient safety. And in this, there are 2 very, very important initiatives. One of them is World Patient Safety Day, and the other one is the Global Patient Safety Challenge. And Global Patient Safety Challenge in particular, there have been 2 previous challenges as well. One on clean care is safe care and the other one on safe surgery saves lives. And now we are currently in the 3rd challenge, which is on medication without harm. So in the next 15 minutes or so, I'm going to touch upon just the overview of these 2 key flagship initiatives, and also would like to have some in-depth thinking and discussion with you how to maximize the impact of these 2 initiatives to bring about the change at the point of care, what we want to see. So I would like to share my slides, and then we could go through some of these extremely important initiatives. We were discussing about the milestone and the watershed moment for patient safety in May 2019, which was the outcome of the global patient safety movement started from the annual ministerial summit series. This resolution on global action on patient safety, we all recognize that established an official WHO World Patient Safety Day to be observed on 17 September. And I must say that we've been, from the area of patient safety, very fortunate to have this day established through the World Health Assembly, because there are only 11 days in the year which have been established through the World Health Assembly, which provide it the mandate as well as the sustainability and the entire organizational support and backing for observing the day, and also not only have it focus on advocacy, but also as a platform for calling for action and for implementation. And year 2019, when the World Health Assembly also recognized that patient safety as a global health priority, and it's not only for that particular year, it's as a strategic priority so that we could address the huge burden of patient harm in healthcare, which is unacceptable. And we want to move towards eliminating avoidable harm in healthcare, which is the motto of the Global Patient Safety Action Plan. So just to go through the text, what the resolution speaks about World Patient Safety Day. This resolution has World Patient Safety Day as 4 clauses. Firstly, it endorses the establishment of the day to be marked annually on 17 September in order to increase public awareness and engagement and enhance the global understanding and work towards global solidarity and action by member states to promote patient safety. Then it also asks and urging member states to mark the day annually on 17 September to promote all aspects of patient safety, including progress towards reaching national milestones in collaboration with relevant stakeholders. And I'm very happy to share with you, when these discussions were going on in May 2019 at the Assembly, it was Dr. Piyawan from Thailand, who was representing the region of SEARO, who actually made some significant changes in this particular clause in adding from all the SEARO countries to add this, including progress towards reaching national milestones, which really strengthened the resolution significantly. The resolution also asks and invites international organizations and other relevant stakeholders to collaborate with member states in promoting and supporting patient safety initiatives, including marking the World Patient Safety Day annually, and then request the Director General to work with member states and international organizations and relevant stakeholders to promote the World Patient Safety Day through launching a campaign and also a calling for action. So this really provided a very strong foundation for the day, and it would, I hope that it lives forever, so that the call for action on patient safety gains momentum and keeps its need and visibility. Just sharing this, the slide which I shared with you yesterday, that I'm going to share these 2 initiatives under the flagship program. One is World Patient Safety Day, and also the Medication Without Harm, the Global Patient Safety Challenge. And this one, these 2 initiatives are also embedded in the strategic objective 1, which is policies to eliminate avoidable harm in healthcare and moving towards zero harm as a state of mind and a rule of engagement. And you can see that the 5 strategies which Nikhil presented yesterday, World Patient Safety Day and the Global Patient Safety Challenges, are embedded in this. And why it says challenges here, because there have been multiple challenges, and in future also there'll be more challenges which will come up. And I will speak about what actually a global patient safety challenge is later on during these couple of minutes. So just to reflect on the objectives of the day, like objectives of any other global health day, this one dedicated to patient safety is to raise public awareness and global awareness, engage key stakeholders, and also enhance global understanding, in particular on public engagement and also awareness of the patient safety issue for patient safety and the demand for safer healthcare. Encourage development of systems and procedures for safety, and as well as seek commitment and support of member states. 2019, as you know, in May, the day was established, and the very first World Patient Safety Day was on 17 September 2019. And working together with all stakeholders and partners and member states, WHO created a legacy and a visual identity for World Patient Safety Day, as a logo as well as a patient safety logo. And this has been really a landmark achievement of creating visual identity. In addition, the slogan of Speak Up for Patient Safety was also given for the very first World Patient Safety Day. And painting the world orange was a signature mark of the day as well. And some of these legacies now we've observed 3 days already, and it lives on. And it's been going from strength to strength. So as I mentioned, the first World Patient Safety Day, Speak Up for Patient Safety, no one should be harmed in healthcare, was a slogan, and this resonated around the world as the very first World Patient Safety Day and created a very strong foundation and the visibility for patient safety globally. Several materials were developed for the very first one, and then of course every year we have been developing materials to support the campaign in all languages. Just sharing some details about the very first one. 105 countries reported that they observed the day, and then there were several activities around the world. And I don't have the time to go into details of this. I have got hundreds of pictures of beautiful monuments lit up in orange, and it's really provided a huge visibility and global solidarity. And you can see tall tower buildings lit up with World Patient Safety Day, and there's several of them like that, which we have, and I'm happy to share with you in case you're interested. And this is a picture of Jeddah in Geneva, which is now lit up every year on 17th September in orange color. And of course, the pyramids in Gaza as well, and several activities, and orange became the color of the day. And also it aligns with the World Patient Safety, the Universal Health Coverage Day, which is really the objective of, and central to patient safety, I should say, central to UHC. So the colors are aligned to the UHC day as well. The year 2, which is in 2020, we were all struggling with the COVID. And the beginning of the year, when we were working towards deciding a theme for World Patient Safety Day 2020, it was a consensus of all partners to focus the day on health worker safety. And that's why the theme was Health Worker Safety, a priority for patient safety, with the slogan of Speak Up for Health Worker Safety. Extremely, I would say, successful and phenomenal day when we had slogan of Safe Health Workers, Safe Patients, and several materials developed showing some sort of a protection or safety of safe health workers and safe patients. And the campaign design extremely well disseminated and adopted around the world. I must say the top leadership of WHO, DG Dr. Tedros and DDG Dr. Jakob, have been fully engaged and fully involved from the very beginning for World Patient Safety Day and patient safety initiatives. And the Health Worker Safety Charter was launched on 17 September 2020, with also initiative of launching annual goals for World Patient Safety Day, which would then provide some very concrete actions to be taken forward at facility level. So this one in 2020 focused on health worker safety, and all the goals which were related to this theme were preventing injuries, reducing stress and burnout, and also zero tolerance to violence, promoting the use of PPE, and also reporting and analyzing serious safety incidents. And again, we had extremely successful global solidarity. All types of cakes were baked, and I can see Kavaldeep is with us today, and he was the first one to have a very landmark cake which was baked for I think every World Patient Safety Day. There have been new designs coming from the International Patient Safety Alliance, Patient Organization Alliance for this, IFO. So you can see iconic buildings, and in Brazil we had several Christ the Redeemer as well. So several important monuments lit up on the 17th, which really gives a lot of visibility and advocacy. Moving on to 2021, Safe Maternal and Newborn Care was selected as a theme. Again, we had called for action by launching a set of goals related to safe maternal and newborn care. And we also actually then started organizing a virtual conference to bring together as many stakeholders and partners and participants as possible. So this, in September last year, we had 141 countries who have joined this virtual conference on Together for Safe and Respectful Maternal and Newborn Care, and almost 1,600 participants who attended. Going again from strength to strength, several important monuments, iconic buildings lit up in the solidarity for patient safety. So this was briefly about the World Patient Safety Day. What I want to also mention is that we are now focusing also on evaluating the impact of World Patient Safety Day, not only through the use of communication products, but also looking into the improvements in the processes and systems. So some of these outcomes of the advocacy and call for action on World Patient Safety Day is these are linked also with the indicators of the Global Patient Safety Action Plan. So the programmatic improvements of World Patient Safety Day we would see through the Global Patient Safety Action Plan, and every year we are looking into also what is the impact of observing the day globally and also through WHO. So we prepare a summary report every year, and all these reports are available as well on the website. So happy to share in case you would require it. So this is the first part of my presentation. Very briefly now, going to another very, very important initiative, which is the third Global Patient Safety Challenge on medication without harm. The Global Patient Safety Challenge has been a change management program which has been produced or presented as a challenge to member states and partners to invest their efforts and calling for action in a particular area or particular topic which has a huge burden of harm and has proven interventions and strategies to address that harm. So the first, as I mentioned, was Clean Care is Safe Care, launched in 2004. The second one was Safe Surgery Saves Lives in 2008. And then there was a sort of a gap of a couple of years where injection safety was also taken up, but not particularly as a challenge under the umbrella of challenge, but a lot of attention was given to injection safety during the intervening time between 2008 and then in 2017, we then launched the third challenge on medication without harm, again, looking at the huge burden of harm related to unsafe medication practices and medication errors. And we had several planning meetings in 2016. I actually took over the patient safety program in 2014. So I was very fortunate to have led and being involved with several of these important initiatives from the very beginning. So we actually had an expert consultation. And I must say and acknowledge Sir Liam Donaldson, who has been the designer, who actually designed the challenge and the scope of the challenge, and as well as the strategic framework. And working with his strategic guidance, the patient safety unit has undertaken several of these initiatives. So just two landmark meetings in April 2016 and in August 2016, where we brought together not only experts and stakeholders, but also brought together several departments within WHO to work together with us, particularly for this challenge, also the medicines department, the essential medicines department. The goal of the challenge, together with the partners, we defined as to reduce the level of severe avoidable harm related to medications by 50% over a period of 5 years globally. So it depends on when one country initiates the implementation of the challenge and giving it a 5-year period to demonstrate a significant reduction up to 50%. And this is something which is an ongoing challenge. Initially, the challenge was given for 5 years, which was from 2017 to 22. And this year, we are now calling for another 5 years of this ongoing challenge on medication without harm. Just to briefly touch upon the objectives of the challenge, is raise awareness of the problem of unsafe practices, develop guidance and materials and technologies to support the setting up safer medication systems, building capacity of healthcare professionals, empowering patients and families to become actively engaged in decisions, asking questions, spotting errors, managing their medication, and also engage and seek commitment of stakeholders, partners, industry to raise awareness. So it's a huge sort of mandate and the objectives of the challenge to address the issue of medication safety in a holistic manner, in the systems approach. And the challenge was then launched at the second ministerial summit in Bonn on the 27th of March, 2017. And this really provided a huge platform when DG Dr. Chan launched the challenge at this ministerial summit in Germany. Then following that, we had regional launches for Eastern Mediterranean region, Western Pacific region, and the other regions then integrated the activities of the challenge and several other initiatives. We also had a launch in the Africa region. This was a major high-level event, high-level forum towards an Africa Patient Safety Initiative, where we brought together key stakeholders. And at this event, where we were discussing together for safer care with IHI, with of course WHO at the center of this, initiating this entire effort, ISQA, and then patient safety movement. And then at this particular high-level forum, then we also had the Africa regional launch of the challenge to call for action for implementing the challenge. And I must say, in partnership with IHI, we actually had 3 countries where several activities were undertaken, have been taken on medication safety as under the umbrella of the challenge. Just to briefly share with you, when we were shaping the challenge for a strategic framework, we realized that if we look at medication safety through a systems lens, there are basically 4 sort of problems we have, and these are the problems which need to be addressed in a comprehensive and systematic manner. This is patients, whether patients are not really aware of what medications they are taking, and the need to increase patients' involvement and medication literacy, medicines as products, particularly the lookalike, sound-alike medications, the health professionals building their capacities and capabilities for care at point of care, particularly on safe medication practices. And then also at the systems level, what the system and the facility organizations have to provide to create a system and practices of safe medication use. And that led to this extremely important strategic framework, which again is available on WHO website, defining subdomains of the 4 domains or activities aligned with these problems you can see here. And then under these domains, we've got which primarily identify the key interventions which are required to address these and to take action again under these domains. In addition, for early action, we identified 3 action areas or 3 priority areas: high-risk situations, polypharmacy, and transitions of care. And I'm happy to mention to you something which is going to be announced shortly, that as part of the medication safety webinar series, which is going on since February this year, the next webinar, which is the 4th in the series, is dedicated to medication safety in high-risk situations, and that will be on the 17th of May. And then following that, we'll have the other key action areas as well addressed as part of a medication safety webinar. We developed advocacy materials and visual identity again for medication without harm. You can see a beautiful logo as well. And then we also had a very beautiful picture created through a very important graphic where pills and capsules were spread over a world map, and that gave a real impression of a problem which is at global level which needs to be addressed. So important advocacy and materials and visual identity as a logo, as well as a picture and a visual identity on the world map. We developed a global campaign as well to improve the interaction between health workers and patients. And this campaign is No Check Ask, which is for patients before you take it, know your medication, check the dose and the time, and ask your healthcare professional, so that there is more empowerment and engagement of patients to ask questions. And then similarly for healthcare professionals, before you give it, know the medications and particularly the interactions, and also check like a checklist, the right patient, the right medicine, the right route, and the right dose and the right time, and then ask your patient if they've understood. And this campaign is something which we would really like to take forward this year as well. So we also developed a video on everyone needs medication sooner or later. It's all available on the WHO website. Several other products have been developed for the campaign, and banners and other materials, and also several resources such as 5 moments for medication safety, an important patient engagement tool, which starts with a mnemonic in English on STARS, which is starting, taking, adding and reviewing, and stopping medication. So these are the 5 critical moments where action by patients and their families can identify the risk of harm due to medication, and then by asking the questions and also improving the medication literacy and understanding the medications, it can significantly contribute to reducing the harm. We also developed this 5 moments of medication safety, rhyming with the 5 moments for hand hygiene, actually, so that we have some sort of branding of 5 moments. And this particular tool is available in mobile app as well, WHO MedSafe, and also infographics, pamphlet booklets and flyers. And I must acknowledge the Network for Patient Safety, which has actually spearheaded the production of this tool for patient engagement, in particular, Helen Haskell and also colleagues from IOPO and particular Kavaldeep. So thank you so much, colleagues who have contributed to extremely important resources on medication safety. We also publish papers in journals to engage the academic and research institutions in Lancet and WHO Bulletin, as well as Global Health. The 3 priority actions, we also have reports released on the 3 areas: transition of care, high-risk situations, and polypharmacy. Just to conclude on the medication without harm challenge, the key action areas, particularly at national level, relate to some priorities for these 3 areas, which I said to get this strong commitment and prioritize and take early action and effectively manage the 3 areas to protect patients from harm, but also looking at developmental programs that in asking countries to convene experts in the 4 domains and then have targeted programs of change for these 4 domains, which I listed earlier. So the success of the challenge depends on high prioritization of medication safety within healthcare system, and also a widespread buy-in of stakeholders, shift to the mainstream of care, and then taking concrete actions and also creating a social movement for involvement of all stakeholders. And I must say that because of the COVID pandemic, the implementation of the challenge has not been as expected, and many countries had to reprioritize activities, and some specific activities which were linked to the challenge could not be taken forward in the most effective way because of reprioritization. So utilizing the platform for World Patient Safety Day, the steering committee, which is working with WHO for advising on World Patient Safety Day, then agreed to dedicate this year's World Patient Safety Day to medication safety. And we hope that the ongoing work of the challenge and the platform of World Patient Safety Day will lead to the consolidation of the work on the challenge. So it's time for action on patient safety has come. Let's walk the talk. Thank you very much indeed, and join us in achieving medication without harm globally. Thank you very much indeed. So I will now stop here, and I will ask for any question, answers if you might have on these topics, or any of the topics which you would like to bring forward for discussion. And thank you, Aparna, for this opportunity.
Thank you, Neelam. We will be taking question answers at the end, and you will be moderating the session. So please take the floor and call Irina for the next stop.
All right. So I think, yeah, I just wanted to give the floor for 5 minutes to any of the colleagues who have any specific questions on this presentation before we move ahead. And if I don't see any hands, I think we are ready to move ahead with the next one. So just let's give 1 minute. If there's any point of clarification you would have on this topic. So as I don't see any hands, right, and nothing in the chat as well. So thank you again for this opportunity. And moving ahead, then I would like to.
Dr. Neelam, I had raised my hand.
Sorry, I couldn't see it. Yes.
Sorry, it's okay.
Yeah,
so this is Tankam Gomez from India. So I have seen the MedSafe application, and I downloaded it. First, I thought it's going to be very useful for nurses, Then I realized that this is for patients. So I just thinking, is there any plan to develop something called 5 moments of medication safety for nurses who are the major chunk of administration and the last point of probably stopping an error from happening? And there is a gap of knowing the essential drugs, their actions and any interactions So I was little greedy when I opened it. I thought it may be something like that, so we can tell the nurses that you can have this app and refer to it very quickly. So I'm just saying the same thing as an aspiration. If WHO can come up with something like that, like an app, where generic names and their actions and drug to drug interaction can be given, the knowledge level of the nurses who are administering the drugs can be definitely heightened. That was one. And when it comes to patient education, my personal experience, I've spent over 40 years in healthcare. Asking the patient whether you understood was not very effective. It was the best way was to teach back, asking them to tell us what you understood, because many of the problems that I have seen, the root cause was that the patient was pretty distracted when it was being told. He just want to know, one tablet here, one tablet there. So I thought I will just share that. Teach back is personally I find most effective way of ensuring that they have understood what we are trying to teach them. Thank you very much for the opportunity.
Thank you, Dr. Gomez. I think both these points are extremely important, particularly on the app for healthcare professionals. The first version of the app was developed in 2019, and it's been now 3 years already. It was launched at the 4th Ministerial Summit in Jeddah. And we since then, we have now looked into whether we should bring other language editions as well. And considering medication safety is a theme for World Patient Safety Day, it's already our plans to look into updating the app. And I will sort of discuss your suggestion of actually developing a similar app for healthcare professionals, particularly nurses, which I'm sure will be very useful. And also on the, on the medication literacy, absolutely. I think these are like simple, innovative strategies and mechanisms which can really go a long way. So thanks so much for sharing your experience, and hope to engage with you and all colleagues in our efforts going forward for medication safety.
Thank you.
Thank you so much indeed. So moving on, we are running a bit late, and I've taken longer than my anticipated time, just because these topics are so vast and so huge, and I'm sure that I haven't done justice to the importance of these two topics on World Patient Safety Day and the Medication Without Harm Challenge. So I would now like to invite Dr. Irina Papiva. And Irina is the technical officer in the Patient Safety Flagship Unit. And Irina, please, if you can speak on health workers, their education and protection, particularly the strategic objective 5, which is dedicated to health workers. Over to you, Irina. Thank you. I can't hear you, Irina.
Yeah, good morning. Good afternoon, everybody. Sorry, some technical difficulties. So I hope you can see my screen now. And I am very happy to be here today with you and present the strategic objective number 5 of the Global Patient Safety Action Plan that is related to health workers' education, skills, and safety, because I'm sure that you all would agree that having a competent and compassionate workforce that is supported by the system is the key to translate all the policies, strategies, and actions into the patient safety improvement at the point of care. So we have to educate, skill health workers, and we have to ensure that they are supported by safe working environment, because health workers that feel psychologically and physically safe and work in safe environment are more likely to provide safe and high quality care to the populations. So moving ahead with these strategic objectives, as all strategic objectives, this one also contains 5 very specific strategies, and we will go one by one to speak about all of them. So to start with the strategy number 1, which is related to patient safety education and training, I really would like to pose a couple of questions to you to think, to reflect on that, so then you can remember the content of this presentation much better. So just think about at which level of professional development should be patient safety should be taught to health professionals. Is it undergraduate level? Is it postgraduate level as a specialization? Is it postgraduate level in service training for different categories of health professionals? Or it should be part of continuous professional development, again, for all categories of health professionals. The second question is related about how patient safety should be taught. Should we have the content that is relevant for each profession specialty? Should we have unified content for all professions? Or the content should be taught in multi-professional environments? And the next question is, what should be taught about patient safety? Is it enough to introduce general patient safety concepts and principles? Should we train health professionals around very specific themes on patient safety, like radiation safety, medication safety, surgical safety, IPC, blood safety? Or we should put emphasis on how patient safety is different in different settings, contexts, and in different groups. For example, what are the specificities of patient safety in primary care or in emergency situations, and what are the specifics, for example, of patient safety issues in children or adults? And answering probably to these 3 questions, I would like to represent you one of the key WHO resources on patient safety education and training, which is called WHO Patient Safety Curriculum Guide. It is quite a comprehensive guide for patient safety education that was written some time ago with global audience in mind, and it can be applicable to very different contexts and cultures. This guide was designed to educate students of all healthcare professions by integrating the core content of it into existing educational curricula, using flexible approach to meet local and individual needs of learners. And this patient safety curriculum guide really builds a foundation of knowledge and skills that will better prepare students to practice safer healthcare. Curriculum guide has quite rich content, and it incorporates different topics. Some of them are health system related topics, for example, how to be an effective player, how to understand the systems and effect of complexity in patient care, how to engage with patient and carers, as well as the guide incorporates some theme-specific topics such as IPC, improving medication safety, or patient safety in invasive procedures. Here, I would like to mention that you can easily find the WHO Patient Safety Curriculum Guide on the website, but our team is now in the process of updating that. And in the coming years, you will be finding standalone modules covering the existing revised topics of the guide, but also with introduction of new topics that proved to be very important in recent years. For example, topics related to safety culture, to clinical governance, topics related to how to introduce incident reporting and learning systems into healthcare, and much more. So the suggested actions in the Global Patient Safety Action Plan for this strategy will be to define approaches to curriculum settings to incorporate patient safety education in professional education and continuous professional development, introduce WHO patient safety curriculum guide into education and training programs for health professionals in your respective countries, and also develop and offer specialized courses on patient safety for in-service training of health professionals of all categories that will incorporate basics and approaches to personal safety. Moving ahead to the strategy number 2, is related to the establishment of the Centers of Excellence for Patient Safety Education and Training. And here again, I would like to pose the question for you that will be followed by the proposed answer. What should be the role of the Centers of Excellence in Patient Safety Education and Training? And what we thought while designing a global patient safety action plan, we thought that the Centers of Excellence for Patient Safety Education and Training should be responsible for designing and implementing educational and training programs on patient safety. They will be also responsible for continuous knowledge synthesis and dissemination, including sharing of best practices. The key role of the Centers of Excellence definitely will be building capacity of health workforce in the country at different levels. And why not to support policy processes in the countries? Because as you know, the education and mostly education of health professionals is the prerogative of educational sector in most of the countries. So it is extremely important that there are designated authorities, centers, entities in the countries that will ensure collaboration between education and health sectors and contribute to the policy processes in the health sectors. And for sure, Centers of Excellence should be responsible for engagement of all key stakeholders at the country level, building partnerships at the country level, but also at the regional and global level. They should be responsible for building different alliances and networking. So the suggested actions in the Global Patient Safety Action Plan is to designate Centers of Excellence in your own countries that will provide leadership in patient safety education and training. It can be one center, but it can be different centers in the large countries like India, and with consideration that in many countries the health is the state subject, probably it will be relevant to designate Centers of Excellence at the subnational level as well. Another suggested action will be establishment of the national network of patient safety centers and also other agencies that are responsible for education and training of health professionals. And another action will be to institutionalize partnerships with healthcare institutions to implement patient safety education and training. So moving forward to the strategy number 5.3, which is related to linking patient safety competencies to regulatory requirements of health professionals. We all understand that transforming education and training of health professionals into the patient safety improvements at the point of care that in long term will contribute to the improved population and health outcomes can be done through the competency development. While competency-based education is a widely acknowledged benchmark for doing that, another way of ensuring that is to link competency development of health workers to regulatory requirements. And the suggested actions in the Global Patient Safety Action Plan is to link individual and organizational performance to patient safety improvements through licensing, relicensing, regulation, and accreditation. is to define patient safety core competencies for each category of health professionals and link patient safety competencies to service standards. As you can see, this strategy is very contextual, and the approach of ensuring that will be very much based on the local circumstances and on the local approaches that are adapted in your own countries. In some countries, it can be done, for example, only through licensing and relicensing of healthcare professionals, while in other countries, it can be done through the standard settings for the service provision. Some countries also follow the approach of incorporating patient safety competencies in accreditation of health care institutions and healthcare professionals. Moving ahead to the strategy number 4, which is about linking patient safety with appraisal system of health workers. And again, question for you to reflect on: what do you think? Do performance appraisals really change the performance of health workers? Some of you may answer yes, for sure, it changes. Some of you might not agree with us. And some of you may say that this is quite a debatable topic and should be considered in the future discussion. I have to say that for the moment, current evidence suggests that there are multidimensional benefits of performance appraisals when they are introduced in the systems. And we know that performance and appraisal systems measure performance of staff against the set standards and set of core competencies, and based on the agreed objectives and goals. And they help actually to understand what are the key achievements and pitfalls in the performance of health workers. It also helps to define future objectives, probably to rethink some objectives and goals in the performance. And why not, it also helps to inform policies and strategies both at organizational and at the national level. So the proposed actions in the Global Patient Safety Action Plan will be to link performance of health professionals to participation in different patient safety programs and initiatives, establish robust mechanisms for recognizing exceptional achievements by staff members in improving patient safety, and promote establishment of appraisal system in healthcare facilities. I'm sure that many of you will relate of this action with what is already going on in your respective countries, but the focus here is really trying to put focus on patient safety improvements and participation in patient safety initiatives and programs. And finally, moving to the strategy number 5, which is related to safe working environment for health workers. There is an increasing attention to and consideration of importance of health worker safety as a prerequisite for the patient safety. And as you have heard from Dr. Nilam when she was presenting World Patient Safety Day, that was particularly linked to the health worker safety. Here I would like to introduce to you the charter that was developed on the occasion of the World Patient Safety Day in 2020, and that called all member states and all relevant stakeholders around the world to support and endorse this charter by signing up to it. The charter incorporates a range of very specific activities to be implemented at different levels in your respective countries that will in long term ensure the safe working environment and as well as psychological safety of health workers. And the proposed actions in the Global Patient Safety Action Plan is very simple, I would say, is just support and endorse WHO health worker safety charter. Then to develop and implement occupational health and safety programs, establishing linkages with other programs like infection prevention and control, blood safety, WASH, and others. And for sure, adopt and implement policies and mechanisms to ensure health worker safety, at the same time allocating enough resources to ensure sustainable implementation of policies, strategies, and programs in your countries. What is important to mention here is that you will hear about monitoring of the implementation of the Global Patient Safety Action Plan later today. But just to highlight here that the core indicators that are set in the Global Patient Safety Action Plan, 2 out of 10 core indicators are related to ensuring safety of health workers and investing into education and skill development of health workers. And you can see 2 of them that we will be looking at the number of countries that have incorporated patient safety programs or courses in the training and education of healthcare professionals. And the second indicator is related to the number of countries that will be signing up and implementing WHO Health Workers Safety Charter. So this is important to remember and pay attention to that when we will be hearing about monitoring of the Global Patient Safety Action Plan and the set of indicators for doing that. Here you can see the core WHO resources that will help you to support patient safety education and training in your countries. And I would like to close my presentation with the words of Benjamin Franklin that an investment in knowledge pays the best interest. Thank you very much for your attention. Over to you, Milan.
Thank you very much indeed, Irina, for touching upon extremely important topic, which actually was the main point of discussion yesterday about health worker safety, and which became extremely visible and important, particularly during the COVID pandemic and the role which health workers play, working tirelessly to manage the COVID pandemic as a frontline. They were called as warriors as well in many countries, and then also and they also suffered harm during that process. So thanks so much for elaborating on the strategic objective related to health workers' safety protection and also inspiring and skilling health workers for patient safety. Is there any burning question to clarify anything on Dr. Irina's presentation? If not, we could go to the next presentation, and it's my pleasure to invite Mr. Kavaldeep Sahni to speak on patient family engagement, which is the strategic objective 4 in the Global Patient Safety Action Plan. Kavaldeep is a great friend and a wonderful collaborator with WHO Patient Safety Program, and he is the CEO of the International Alliance of Patient Organizations, an extremely dynamic and proactive professional, and I'm really impressed with the leadership he's provided for this area of work for bringing together patients organizations around the world. And IOPO is also an official NGO or a non-state actor in official relation with WHO. So we have long-term collaboration with IOPO. Over to you, Kavaldeep. Thank you. Thank you for joining us today.
Thank you very much, Neelam. Firstly, I must thank everybody for having kept us patients safe during COVID. I think as the specter of COVID really goes out, we must thank you all who have helped us. Secondly, I must thank our chair, former chair, Dr. Ratna Devi, who has joined us here today as well, for having driven us through this critical phase, years of really bad public health. I think she's done us really proud, and she's pushing things forward with the the Patient Academy and Patient Safety Program that she's undertaking in SEARO. And lastly, I've seen other people who are here who have been with us on our various meetings on patient safety. I'll start what is called a no frill, no logo basis. We are talking about the Global Patient Safety Action Plan. You heard about it, how we really welcome this. It was the first time that such a plan had been put on paper and unified all the issues regarding patient safety. I'm particularly attending to 2 points. It was strategy 4, which you heard clearly, that is to engage and empower patients and families to help and support the journey to safer healthcare. But more importantly, I'm also linking in strategy 7, where it's about developing and sustaining multi-sectoral and multinational synergy, partnerships, and solidarity. You know, we are not only citizens of foreign countries, we are also global citizens, and we know of engagement is international. It's patient-to-patient communication. Patients in India are talking to patients in Sri Lanka, patients in Sri Lanka are then talking to patients in Malaysia. Malaysian patients are talking to Indonesia and to Nepal. So therefore, we can make those changes that we need in our infrastructure. What are we required to do? First is that we as patients must co-develop policy and programs with patients. So that is your mandate. If someone asks, you have no room in this health system, why are you coming? And in Hindi, you know, it's yang kya kar rahe hain? Then you say, well, we have come for on point of 4.1, that we are here to work with you. We also, when you're talking to them, they said, why are you telling me this? We are taking 4.2, say we are narrating this patient experience. Either you listen to us or the press does. The choice is very simple, but please listen to us. Then I think 4.3, I've noticed Dr. Arora is here. Some of the patients for patient safety advocates. Dr. Arora is one of the champions, has been quite forthcoming and developing, same as Dr. Radna and the others I've seen here. So please develop these patient advocates and patient safety champions. Then again, about for safe, I think 4.4 has to be really addressed in Asia Pacific, that we must not drive patient safety incidents into the dark corners of our health systems. This must be looked in the open light. In USA, as you saw, the Rwanda case where this nurse was being charged on criminal law, which is very retrogressive approach to healthcare system. We should have had open discussion. And then lastly, on the information and education of patients and families, you must engage them. So you've got these 5 strategic things you have to do. Firstly, take charge of that policy development process in your systems. Go there, learn from patient experience, share your experience, develop your patient advocates, and start developing those patient safety in there. You will report them. We'll be coming to you later in the year, as I've spoken to Neelam a number of times, that you must be reporting this to us and to your system and to the WHO as well. This must be reported incident somewhere that we must look at. The government might try to push them aside, but we can. And lastly, education. And I think I saw that the Patient Academy and other entities are developing in that region to look at them. Number 7 talks about synergy and partnership. I think this is about whole of stakeholders. We have to work with that, which means everybody who is involved, we must work with them. We must develop a common understanding. I think this is one of the things that if we understand this is our system, our health, our resource, our future, then we all come together. We must have that patient safety networks and collaboration. I encourage you to join the International Alliance of Patient Safety, also International Alliance of Patient Organizations, Indian Alliance of Patient Groups, you've got Sri Lankan groups. Please join this. I also look at the cross-geographical multi-sectoral initiatives in patient safety, and let's make sure we help align all these technical systems. Where do you start? I think it starts with you. Walk the talk. I think your first step is you have to take that. Please be proactive. Go to your health systems, start talking to them, introduce yourself, be assertive. I don't say force your way into the door. Be assertive, write to them, be there, show that integrity and first step and trust, and say, we are here to help you. How can we help you? Then there's the idea of push and pull. We know that every time either we have to pull things through patients and families and publics, or we have to push things down the policymaker routes, political commitment or private sector commitment. The choice is ours now. Both strategies work. If patients and families are good enough to pull this through policies, to say to the health providers, there is this global patient safety action plan. You have to be compliant to it in one way or the other. You must look at this and you must work with us, or we can then ask the governments to do it. And I think when you've got health systems that split between private and public sector, then that private sector commitment is really important. We would like to see them come in with us jointly in fair and honest discussions. In the political push, who is the government? I think this is something we always fail to define to our families and patients. Our government, again, in the Global Patient Safety Action Plan is clearly defined. You have in the national and subnational governments, you've got the federal and the state, local government, even the small village, panchayats and grams, ministries of health is government, specialized agencies that are there, like rural workers in Thailand, etc., occupational health industries. Then there are other ministries as well who play a big role in our health. And I think patients and families are really good. Ministry of Education for childhood health is really good. Patient safety in there is very important. Then ministries of justice and other consumer affairs are really proactive now. And I think something that I've always said is sometimes the coroners as well are really proactive in that when then you have a whole range of regulatory bodies. I think in India and other places where, the health systems is split between the state and the private sector, then the private sector is controlled to regulatory bodies. And very often these regulatory bodies haven't got the know-how how to engage patients and families into how they can license this, setting standards, accreditation of these hospitals. How do we check whether these hospitals are compliant? As you know, every other day some scandal breaks out around the world where a hospital has remained unchecked or there wasn't any standards body checking them. Questions should be doing that. I think we should be collaborating. Then who is the public? I think, again, this is something that we said that your public is much wider. For instance, you look at the intergovernmental organizations, then entities like the European Commission, India and others are belonging to APAC, Asia Pacific Economic Cooperation. You've got your international and non-governmental organizations, local. International development agencies are there. There are standards bodies as well, the ISPRO, the bodies from ISQA, the quality assurance, patient research. Then you've got international professional bodies. You've got international or the World Medical Associations, International Council of Nurses. All these bodies are there to be interacted with. Then the universities, we must bring this patient perspective to patient safety to the curricula. I was listening into a last patients safety webinar last Saturday conducted by the Patient Academy, and I have Dr. Srinath here who spoke very well about this, that we must develop that curricula and academy. I think they were excellent speakers. Said we must engage those universities and bring them in, because that's where we start developing future doctors and future health systems. And lastly, research institutions. I think they're very important. We must put research into practice and practice back into research. It's very important for us. The public, again, something that we say, we are not alone. We've got other bodies there. You have consortia that are helping in, economic consortia, either developmental or otherwise. Trade unions have really improved things. Indian railway workers or railway workers in Thailand, etc., who have helped improve patient care in their own railway hospitals, etc. Again, the army again has come in, whereas army hospitals have been improved. Community groups, and then the media. I think the media needs to be brought in early on. It's a case of engaging the media, not only for the sensational scandals and things like that on patient safety, but also on positive move for education and etc. United Nations, as always, has been there. You've got your development funding partners, Save the Children Fund, etc. We are working with FIP, which is the International Federation of Pharmacists. And again, the pharmaceutical and medical devices industry is really important. Please work with your pharmacy industry, especially on labeling, on issues of that, on QR codes on products. Again, the health information technology industry, I think, at the moment in SEARO is the largest area now of providing some of the largest companies like Infosys and others who are really improving AI in healthcare and patient safety. Please engage with those. Again, health insurance and maintenance organizations that are very important. Please engage with those as well. So please have a look at the Global Patient Safety Action Plan. Again, the list is there. All the work has been cut out for you, and you can take this forward. On the groundwork, I think this is something that patients and families have always felt intimidated. I think this is where we have to develop that capacity in them to be able to talk to the hospital carers, organize within the hospital. I know this is sometimes not seen as the role of families. Families think that all we do is take the patient in there, get them treated, and take them home and forget about things. No, please do take care of your health systems. They're yours. In many cases, in UK, for instance, our taxes pay for this. Because of that, there is a high loyalty and high engagement factor from the local community. The NHS is like almost a sacred entity for us, and we don't allow it to be messed about, as we say, and it can cause elections in sometimes if you're not careful. So we must love our healthcare systems. They are ours. We pay for it in one way or the other, and therefore we must be farmers and constant gardeners of these health systems. And looking at mental health care facilities is something that I'm very passionate about. At the moment, we're trying to form a mental health alliance in this to look at how mental health patient safety is conducted. I think it's one of the worst records worldwide. Again, there's some specialist clinics and substance disorder facilities. I think cohesive care in some places is really bad in dementia as well. Deprivation of liberty and accidents happen. Outreach is important. Don't forget the rural health workers and subnational districts. And to conclude, I would say that the journey starts with you. It is your role, your responsibility, but don't forget your family and friends. Don't forget the support that WHO in country is giving you. That's I call the information haven. WHO staff are always welcoming, always supporting you. Do look at some of the sites. We could work on that. And lastly, I think we have our several things that we are conducting this year. We have our Asia Pacific Patients Congress coming up, and then we have a Global Patients Congress. We're planning for Oman, Asia Pacific Congress in Thailand. Please do join them, and let's see how we can work together with you and WHO. And WHO will be sharing the Global Patient Safety Action Plan on both of these congresses. And I wish you all good luck in this, and please join us and let's keep the world safe. We have a golden opportunity now. There's political will behind us. People have realized that our health systems cannot be unsafe, and we cannot continue the way we had been doing in the past 75 years, which is WHO's history of great work, but let's push forward. Thank you.
Thank you so much, Kavaldeep, for a brilliant presentation and also introducing several new concepts, the whole of society approach for addressing patient safety, and also health systems are ours. I think that's really something, we have to contribute to health system for its safety, and they are really our system. So really appreciate you taking time and sharing your thoughts and vision with us. So any questions to Kavaldeep for any clarifications at this stage before we go to the next presentation? at this stage, we have no question, Kamaldeep. So moving on, thank you, Kamaldeep. Thanks so much. Moving on, I would like to invite my colleague,
Neelam, two questions, two
Yes.
colleague raising hands.
Yeah, I'm not somehow able to see hands. So yes, please.
Asanti and Dr. Arora.
Okay, I can see now. Yes. So over to Basanti and then to Dr. Arora. Yes.
Thank you very much, Dr. Neela. Regarding the first, this thing, in India, we are fortunate that the curriculum exists for the undergraduate course in medicine. And one thing which I thought about Irina's talk was, how do you handle altercations between the different categories of healthcare workers? For example, doctors and nurses. We saw a news today that a nurse had assaulted a doctor and was forced to be suspended in one of the institutions in India. And also among nurses and the workers working under them, it has been happening, though not reported. So how are these issues to be addressed? If some guidelines could be there for that as well, I think it would be helpful. And regarding Kamaldeep's talk, it was a very important point made that media should be in a positive mood. That is the most important thing, I think, because by and large, they blow up situations, fine. There is hardly any follow-up on anything, say, for example, a kidney racket or anything. The real truth, the ultimate truth about a situation that they've reported is never followed up and reported again to the public. So nobody knows beyond whatever is raised in the beginning, but the final outcome. And mental health, patient safety is extremely important, because in some countries, they also have the rule that unless the patient consents in mental health, they cannot be treated. But many patients with mental health problems are not in a position to give consent and hence are denied. So these, if they could be addressed, I think it would be very useful.
Wonderful recommendations, Dr. Basanti, and particularly on the part of mental health settings, I think that's an extremely important point. And I've seen that IOPO has had several initiatives addressing the safety issues for vulnerable population in prisons as well, and also in mental health settings. So points well taken. And I think what we'll do is we'll just take one more question or two more. I see Namal Chikunia. Irina, over to you to respond. Yeah, let's go ahead.
Yeah, thank you very much, Neil. I just wanted really to provide very quick feedback, because the question raised by Vasanti is very much important. And just to highlight, it's important what we teach our health professionals. So we teach not only technical skills, we don't only explain what is blood safety, what is IPC, and what are the standard operating procedures, what are the standards, but it is also important that we teach how to communicate in a team, how to be an effective good player. So-called non-technical skills are equally important when we consider education and training programs for health professionals. Another important aspect is how we teach. And there is a global movement of introducing multi-professional approach to education, which means that you bring all health professionals together and teach them together. There are not many universities that are applying this approach, although it proves to be quite effective in addressing those issues you have raised in your question. So when we will be revising the WHO Patient Safety Curriculum Guide, we will be considering what to teach with focus on non-technical skills and also how to teach. We will be promoting teaching patient safety in multi-professional environments. Thank you. Thank you.
Thank you. Thank you very much, Irina. So we'll take two more questions and then we'll go to the last presentation of this session. Over to Dr. Arora.
Yes, ma'am. Thank you, Kamalji, for your wonderful presentation and giving new ideas. I have what we have seen whenever there is a problem in any institute, especially the government institutes, When you go there and try to interact with the patient and the healthcare worker, if any problem arises, they don't allow us to engage with the patient or talk to the patients. We are saying, who are you to talk to them? So that is a problem we are facing very regularly. And if we ask that we'll call the media, that will further increase the strained relationship. So how to overcome that?
Thank you very much, Dr. Arora. And as you saw, we had been saying we need to create that enabling environment for patient engagement. I think we have to start with that. And that was suggested several times. You saw Sir Leon Donaldson also talk about, and then Honorary Jeremy Hunt talk about this, that we do need to look at maybe a framework, whether this is through legislation, policy, or practice standards, of a institution patient engagement in health safety within health systems all over. We do need to create that. That's your right. And then there's a culture. I think that one again, Neelam has also expressed this very wonderfully, is that we have to be working at developing that culture. And Dr. Vasanti's again could be answered with that. Developing that culture of cooperation, collaboration, co-production, and bringing that forward. And I think where carrot and stick issue needs to be done, we have to look at it carefully, how we do that. We do not antagonize anybody. We would like to see hospital associations. I'm bringing this issue in Dubai, in the International Hospital Federation's meeting, that we should look at hospitals as open door policies to encourage patients in, bring patients into the main management, place patients in all levels of structure of the hospital, make sure they're incorporated. And if you don't do it voluntarily, then the route is to public engagement with the legislation of the country and make sure both the private sector and public sector has got patients instituted at the heart of all decision-making and reporting systems. That's the way to go. I think we need to walk that talk now. We have a plan. And thank you very much for your efforts in India. I think I really like what you've done. Thank you.
Thank you.
Wonderful. Thank you so much, Dr. Arora and Kavaldeep. So the last question before we take the next presentation is, please take the floor, Dr. John. Can't hear you. I think we've lost him.
Dr. John, you are on mute.
Can you hear me now?
Yes, can hear you very well.
Can you hear me now?
Yes, wonderful. Yes, absolutely. Please go ahead.
I hope you can hear me now.
Yes, yes, yes. Can hear you. Please go ahead.
All right. Yes, this one is to Mr. Kamaldeep. Do you have any models along which you've had successful society and public engagement with physician communities? Because I think in the future, it is almost certain that, sadly, many of us, even as members of the public, are going to face potential harm in healthcare settings, which is sort of almost certain, because that's the nature of human interaction. We need to get sort of ready up in front about this. Going by clinical experience in India, it can be extremely traumatic to us as physicians, despite our best efforts. There was a recent case of a lady doctor committing suicide because of a very hostile reaction from the public and, in fact, law enforcement. So I think it's time we need to go proactive on this. I really congratulate what Mr. Kamaldeep is doing, to raise awareness. It would be lovely if WHO could take leadership. We'd be happy to help out in whatever way. Let's get to the public and society and tell them your likelihood of being harmed in a healthcare setting is extremely high, and let's prepare for that. Sorry to put it in a negative way, but that's the reality.
No, thank you, Dr. John. I think the model that, again, WHO has provided an excellent solution. These are patient charters. They're part of that plan. If you look at that on the plan, it says creating those patient charters. The patient charter gives mandate then for public engagement. In the UK, the NHS, as you know, the NHS was formed in 1948, so it's the oldest. It's the grandmother of all universal health coverages. And as a grandmother, it's made a lot of mistakes in its life, but has learned from them. So the NHS has really improved in that sense through learning from its mistakes. It has got its own NHS constitution. That constitution is recognized by law. the Constitution gives room for patient charters. Those patient charters are now legal documents which can be used in what is called alternative dispute resolution in the courts. The court systems are aligned. So we have all alignment. That's the model. So when somebody turns up at the consumer court in India, they have this right enshrined straight from the ward to the court and from the ward to the parliament. So that's how our NHS constitutions are based. And when the founder of the NHS, Lord Bevan, said was that whenever, say for instance, if we paraphrase for Indian situation, a bedpan falls in Assam, the sound of that bedpan should be heard in New Delhi at the parliament. That means that's how connected you should be to your health services. The parliamentarians must be connected totally to that. So yes, thank you.
Brilliant discussion. And Dr. John and Kavaldeep, I think particularly on the issue of interprofessional education, the new approach is to actually moving towards the patient-centered approach in the real sense. We then have all professionals working with the patient-centered approach. And that's where the empowerment would really occur. Because I'm seeing comment from Dr. Vasanthi again about verticalization, if we have different cadres. So extremely important to have the interprofessional, multi-professional approach for patient care and with a patient-centered approach. So moving on, thank you so much indeed to all questions and for speakers and participants for raising these important points. Moving on to invite my colleague, Ms. Maki Kajiwara. Maki is going to present to us the WHO technical guidance and report on patient safety incident reporting and learning systems. Over to you, Maki.
Thank you. Hi, everyone. My name is Maki from Patient Safety Flagship in WHO. Then I'm going to explore WHO work on the patient safety incident reporting learning systems. So at healthcare setting, I think you may know this more than me. What went wrong, the things that go wrong, it is essential to understand what happened, why it happened, and what were the consequences, and what can be done to mitigate the harm caused by it, and what can be done to avoid this from happening again. Patient safety incident reporting learning systems itself is to support in improving the patient safety by learning from patient safety incidents. Since the inception of WHO Patient Safety Program in 2004, we published 4 technical documents in this area. First one is draft guideline of patient safety, adverse event reporting learning systems. And second one is the international classification of patient safety, which includes a conceptual framework. This conceptual framework and this classification is now incorporated to the ICD-11. In 2016, we developed a minimal information model for patient safety, which allowed any settings at hospital or national level to start collecting the incidents, but with using the minimal set of the information categories. And then 2 years ago, we developed the patient safety incident reporting and learning system, technical report and guidance. This guidance are all inclusive, covering everything we've published since 2005. So if you read this guidance, you can capture all the information we developed past. So when we set incident reporting learning systems, it has this conceptual approach. The firstly, incident report is that data need to be reported. And after the report, the team needs to assess the report and to investigate the causality of that incident. And also need to conduct the system insight analysis to develop, to bring the learning component, to retrieve the learning components from that incident, and distribute that learning components to avoid the future harm. So it means the incident reporting learning systems has the mainly three components. First is reporting incident. Second one is analysis of the incident. And third one is the retrieval of learning and dissemination of it. So firstly, reporting patient incident. As I said, minimum information model is a great start point to start point to collect the patient safety incident. This information model actually has the two different information category sets. One is the basic one, second one is advanced one. But basic MIM is the very good starting point, and it means it's the minimal information. That means you can get more information on the incident report form, but minimally we need to get the age, sex, and incident time and the incident location, and what happened information also need to be collected, and the incident type, outcome, and the resulting action, the reporter's role need to be collected. Both model has the free text area because this is the very important information source to dig into that incident analysis. The advanced MIM has the cause, the contributing factors, mitigating factors section, but this is at the starting point, it's not easy to collect this data because this need to be brought from the initial analysis of the incident report. So that's the reason why we usually recommend to start with the basic minimum information model. So after collection of that incident data, so the analysis of that incident is very important. So firstly, you can run the individual review, and also if the incident is very serious, a fully investigation need to be done. But those individual incident analysis doesn't bring any systemic insight. So that's the place that aggregated study comes in. And then the table on the right side shows the types of the aggregated analysis of the incident. I don't dig into this table, but it says that there are the different types of the activity which has the pros and cons. For example, surveillance, the source of analysis, all types of the incidents, but it highlights the broad pattern and trends, but weakness is systemic. Weakness is that the little immediate action, it means that it takes time to analyze. So depending on your needs, you need to choose which analysis tool will be selected and used. After going through that analysis, you can get some learning components from that incident analysis. To implement that learning component at the practical level, at the healthcare settings, there are several ways to do that. One may be the webinar, one may be the teaching. Then I'm going to introduce the patient safety alerts. So it can be developed in the hospital level, either the national level as well. So this is the example of the patient safety alert from Saudi Patient Safety Center. This is one of our collaborating center. So the title is the preventing delays in patient management within the emergency department. On the right side of this slide, you can see the event. It says 16 events delayed reported, and 15 of these reported events resulted in death. And then this report alert includes the contributing factors and the effective team communication and the SOP. So this is very short document, one-pager document. Second page has the references. So this, after developing this type of alert, that will be distributed to the hospital and usually put on the ward, and every healthcare staff can see and take action. This is second example of the patient safety alert from Japan. The title is Burn While Bathing a Newborn and Infant. So this also has a 2-pager alert. The second page has cases information with some SOP. And the first page shows a small illustration on the bottom of the page because it's easy to catch eyes what to do. So it says the right temperature for the baby to be put underwater, and that thermometer need to be inside the water. We've been working in this area for years, but still challenges are remained. First one is underreporting. So I think that yesterday and today, many people, many experts already pointed out the fear to report incidents still huge issue, and also lack of understanding what to report also make hesitance of health workers to report the incidents. The second one is the reporting culture and the environment. So still blaming culture is across the world. This is a really common challenge in any nation. Also lack of legal system or the policy environment in particular to protect the health workers. Also a challenge for making report of the patient incident. The third one is capacity to report and invest in patient safety incidents. So although you start running the patient safety incident reporting learning system, you got a bunch of the reports, but if nobody can analyze them, and then nothing may be changed in the patient safety. So capacity, building capacity in the analysis, it's also very important. And once you run the incident reporting learning systems, the data keeps coming, and the capacity of people who can, the team who can, which can analyze the data is limited. Reporting learning system. Also, patient reporting, as the colleague mentioned, engaging patient is quite important because patient family is the only people who go through the entire patient journey. So they will be the safeguard to raise the potential risks, and also they will make their report because the incident happening. Once the incident happens, it's better to have the multiple angles of the report, because the eyes from doctor is different from the eyes are different from the eyes from the nurses. So the patient eye sometimes very useful for us to go in going deeper of the analysis of the patient incident. So this is almost final slide of mine. So about the activity in SEARO, yesterday, MOH, Minister of Health Maldives, Slovenia, a little bit introduced our training we had with Ministry of Health and WHO country office and the regional office. We ran the patient safety incident reporting learning training last month. The more than 200 participants are nominated. And then the training itself covers the fundamental knowledge of patient safety incident reporting learning systems. Facilitators are from Thailand, Piawan, Dr. Piawan, and Sri Lanka, Dr. Suri, and also Ronel, who is going to introduce the patient safety reporting learning system in South Africa after my presentation. Then I think that session went very well. We recorded everything, and now all the materials are available on WHO website. If you're interested in start learning of the patient safety incident reporting learning system on the implementation perspective, please go to WHO website to get that knowledge. And then now we running the incident analysis workshop. We had one session last week, and another session will be held tomorrow morning. Then we had the facilitators is WHO Collaborating Center, and we limit the number of participants of this workshop because we need to dig in to the actual analysis of the data in that workshop with getting the feedback from the facilitators. This contents will be also available on WHO website, but if you are interested in working with us on this training development, or if you would like to take the training from us, please contact your country office so that we can start discussion on it. So this is some to capture some of the screenshot of our training. So left side of the slides are available on the WHO website. It shows different types of the approach of the reporting learning system in different countries. And also the London protocol, how to analyze the incident, also the fishbone diagram used in that workshop tomorrow. Also captured like this, and all the participants from the Ministry of Health and those hospitals and entire motives are captured on the right side of the slides. So takeaway point, includes 6 points. The first is the patient safety reporting learning system is very important mechanism to improve patient safety. And if you would like to start collecting data, please start small. For example, you can focus on incident type. You can limit the incident type like inside the medication safety, for example. This is one way you can start small. Then definition of the incident type is also very important to be defined in advance. So I really like you to discuss what types of the incident are easy to collect. So starting the incident collection of the incident doesn't need to be very difficult. So you can start, for example, collecting the information of the nemesis is also okay. So just that you can discuss inside the team. Also capacity building, how to collect, analyze incident reports, and how to retrieve and the dissemination to support, also important skill set to be developed. Also blame-free culture, anonymity reporting, and the leadership, the key drivers, and encourage health professionals to report patient incident. And also engaging patient and family is quite important. Their story really inspired health workers or anyone on the planet to realize the importance of the patient safety, and also they can support to identify the potential risks. Thank you very much. My presence is done.
Thank you so much, Marky, for a wonderful presentation, and the takeaway message is extremely precise and extremely focused. So I would also like to acknowledge actually Sir Liam Donaldson, who is the WHO Envoy for Patient Safety and is the main author for the WHO technical guidance and report on the patient safety incident reporting and learning systems, which Marky presented. And I want to actually quote Sir Liam as well. He had mentioned a couple of years back, actually, it's a very quotable quote that to err is human, to cover up is unforgivable, but to fail to learn is inexcusable. So I think, seeing the interest in this meeting and yesterday and this presentation now, reporting and learning systems are really the bread and butter of patient safety. So, this is like the most fundamental and the most important strategy to learn from what has gone wrong so that, we don't repeat our mistakes, and we put in place corrective measures and preventive measures for improving patient safety. Thank you, Marky, again. So any questions to Marky before we are ready to close this session? Aparna, yes, please.
Thank you, Neelam. Two things. These are not questions, two responses, because there are a few things in chat box. So some of the participants are requesting the recording of this 2 days informal consultation so that they can use it in the countries. So yes, we can do it. We can make it available on our website. The recording, it should not be difficult, number one. Number two, I would like to announce that we have already piloted incident reporting learning training in Timor-Leste. So in the same way, we can do it for other countries. So if you're interested, please send your request through your country office to us, and we would be more than happy to conduct these trainings for your country. Over, and thanks, Neelam. Over to you.
Wonderful. Thanks, Aparna. Dr. Gomez, the floor is yours. You're muted.
Okay. Hello. Yep. Can
Yes,
you hear
please.
me?
Yes.
This last part, Ms. Mackey has really the right way to look at. And I totally believe what Dr. Neelam said, that failing to learn is definitely inexcusable. And that's something that is really ailing. I feel very close to my heart. And many times we like to be in the cloud nine, not acknowledging what is happening, and then we actually tend to make mistakes again. I'm really touched with all the initiatives. I really hope that we all can together make a difference. I want to request for a training because I'm a nurse by profession, and I think nurses can make a lot of influence in the patient safety, and that cadre is not yet tapped well. Somehow, when it comes to discussing patient safety, nurses are usually not in that table. It's all discussed by many other discipline, not exactly the nurses. I think that's one cadre that needs to be really tapped. It's very heartening to see countries actually making progress in the patient safety reporting system, and very heartening to see how it is being showcased that how to prevent rather than looking at who did, how it happened and what can be, given a blame tree. How do we popularize all these learnings from Japan, Maldives that you have showcased? I think more and more such workshops, and I'm sure that learning from error is an automatic outcome of reporting systems. So I'm really very greedy, thinking that how can we get this training to as many people as possible. And I am immediately requesting, because we are an association of nurse leaders and they can make a lot of difference. So we really hope that we can bring in a workshop, and getting uh, 25 is definitely not a challenge at all. And from maybe that can snowball into something, really. Uh, I am very passionate about it. So sorry being a little emotional. Thank you.
Thank you, Dr. Gomez. Actually, you've shown us the human side of patient safety. We all get affected with patient harm and we want to make things happen, and emotion actually drives the passion. So thank you so much for sharing your views and time. And as Maki highlighted in a takeaway message, that starting small itself is very, very important. Maki, do you want to respond?
No, I also became emotional. Thank you very much, Mr. Dr. Gomez, about their sharing. Thank you very much.
Thank you. Dr. Sangeeta Sharma, over to you, please. Could we unmute Dr. Sangeeta Sharma, please?
Yeah, thank you, Dr. Neelam. I fully agree with Thankam, and we at DSP RUD for last many years have been, addressing this, especially the medication safety part with nurses. And believe me, our experience of training the nurses has been really, really very, very good. They are very enthusiastic, and also because they also form the largest workforce in an hospital. So, and medications are administered by the nurses, and so we should try and bring them into the mainstream, especially when we are talking about the patient safety, developing that culture. And we want that more and more reporting to take place, because they are in best position to identify the errors and report them. Doctors sometimes are not able to detect it, but they are in a very good position to detect these errors. Secondly, I'm after listening to all of the experts here, we all of us agree that we need to do something about it. And healthcare is an area where we can't say that no errors will happen, but at the same time, if you because we do a lot of programs with the patients as well, we need to keep this cultural attitudes and beliefs also in mind when we are advocating about the patient safety. For example, at current times in India, anything going wrong with the patient, any negative outcome, be it the illness stage or it could be the natural course of the disease, or it could be the natural complication already reported. Patients consider all of these as medical negligence. So I am really I've been doing this for last 25 years, but I'm really now thinking on when we say errors, it rings bells in the minds of the general public, and they think that this is negligence, whereas we know, so we need to cater to this part of it. Unless this is addressed, the culture of reporting and learning will not improve. Similarly, for example, clinical audit has been considered as a educational technique, which with which you are able to learn the gaps and improve upon the systems. But even with doctors, the word just that we are auditing the practices or any other area, they become offensive or defensive. So I think we need to look into this. How can we use this word errors carefully when we, especially when we are talking, communicating with the public.
Very true. Absolutely. Thank you very much, Dr. Sangeeta, for extremely important points, particularly related to the need for legal protection of health workers, to promote reporting and separating medical errors, which may be system-driven, from malpractice or negligence, which could be individual accountability and responsibility. So
can we, just a minute there. Can we use this word safety event rather than errors,
Exactly. So we have actually moved away from adverse events to calling it patient safety incidents.
Yeah.
And that's something which I think it's slowly and slowly we have to promote more and more. And sometimes for explaining to people, they simplify the as patient safety incidents and errors. But I totally agree with you that we should move away from the words error, because that might show that this this is something which was done because of negligence rather than something which is actually systems driven and could be addressed. So we've come to the end of this session on systems approach to patient safety, and we actually touched upon several strategic objectives under the umbrella of the Global Patient Safety Action Plan. Strategy 1, were related to World Patient Safety Day and the challenge, and also strategy 5 on health worker protection, skill and safety, patient and family engagement, which is strategic objective 4, and then also 7 about synergies and partnerships. And Maki in the end presented the reporting learning system, which is part of the information as well as research and risk assessment and improvement strategy. So this is truly a systems approach to patient safety, and extremely important feedback and comments have come up. Time is always limited, so we will not be able to take any more discussion at this stage. But before I hand over to Nikhil, I would like to immensely thank all of you, all the speakers and the participants who generated some extremely important discussion during this session. So thank you once again, and over to Nikhil Gupta for chairing the next session on best practices in patient safety implementation. Nikhil, over to you. Thank you.
So thank you so much, Dr. Neelam. And because we are running a bit late of the schedule, without further ado, we have a very, very august panel of experts here. Those will be sharing some country experience on the areas that we just talked, like patient safety incident reporting system, and how to have a systems approach and embed patient safety in the public health programs, and also how we implement patient safety at the hospital level. So we have 3 experts here. And first of all, I will be requesting Dr. Ms. Ronald Steenhobel to present on the patient safety incident reporting and learning system experience in South Africa. That is one of its kind, very much aligned with the WHO guidance. And all the countries here can relate because it's coming from a middle income country, and it's very much feasible to implement in the Southeast Asia region also. Over to Ronald.
Morning, everyone. Thank you for the opportunity to present to you today South Africa's experience in developing a patient safety incident reporting and learning system. Nicole, can you just confirm, do you see my screen? You do? Okay, great. Let me just put it into slideshow view. Yeah. So today, the content of my presentation will be just to give you a little bit of background of South Africa's health system. Then how did we go about to develop our national guideline for patient safety incident reporting and learning? The purpose of the guideline, what do we report, our web-based information system, our findings after 4 years of implementation and the way forward. So South Africa is located in the southern tip of Africa. Our health system is guided by the National Act number 61 of 2003. The Ministry of Health sets policies and monitors implementation. The 9 provinces within the country is responsible for providing healthcare services, and they function autonomously. The 9 provinces are subdivided into 52 districts, and we have a population of around about 56 million, of which 80% use public health services. We have about 3,426 primary healthcare facilities and 422 hospitals. So why did we develop the National Patient Safety Incident Reporting and Guideline? At the time, we had no national uniform system to report patient safety incidents. Therefore, we did not know what type of patient safety incidents occur to inform our strategies to improve patient safety. At the time, the World Health Organization also made a call to countries to develop a national patient safety incident reporting and learning system. We also have increasing costs of litigation, and in 2015, a medico-legal summit was hosted by the Minister of Health, and one of those recommendations was to develop a national reporting system. We also have a regulatory body for accrediting facilities on norms and standards. And included in the norms and standards is also standards that facilities must have a patient safety incident reporting system. And the audit results show that only 35% of facilities comply to the measure to have a patient safety incident reporting and learning system. So our first guideline was published at the end of 2017. Our financial year runs from the 1st of April to the 31st of March. So therefore the implementation date is also always on the 1st of April. So the implementation date of the first one was on 1 April 2018. We then did a revision in 2021, and we implemented the guideline, the revised guideline now on the 1st of April. Also, just I want to say thank you to the WHO who guided us with the development of our first guideline, especially on the minimum information model. They reviewed our first guideline and really gave very good inputs before we actually publicized it and finalized it. The revision of the guideline was prompted by 2 documents. Firstly, we published an annual patient safety incident report that in the last financial year's annual report, we included, it was included an analysis of 2 years since we started with the patient safety incident learning reporting system. The other document that prompted the revision was the WHO Global Patient Safety Action Plan that we've all heard a lot about this morning. So why were the revisions done in the second version? When we did the analysis of the 2 years data, we realized that the aggregated data that we got did not give us meaningful analysis, because we needed to add some additional sub-classifications there were also other factors. It was not only the sub-classifications, but we realized that staff did not understand how to classify the PSIs, and we really needed to do some further training. Then the second document was the Global Patient Safety Action Plan. So we looked at specifically, there are advanced and core indicators. So it's specifically in the advanced indicators where there are specific indicators that we did not have in our classification system. Therefore, we revised it to include those advanced indicators in the Global Action Plan. So the purpose of the guideline is to provide direction to the public health sector of South Africa regarding the management of PSI reporting. It's also to give guidance on appropriate feedback to patients, family support persons, and clinicians, and also to share lessons learned to prevent reoccurrence from patient harm and to improve patient safety. So what do we report? And Maki also referred to this in her presentation. So you will see it's very similar because we use the minimum information model. And just also to indicate, as Neelam has also explained, that we use the definition for patient safety incidents of the World Health Organization. We tweaked it a bit for our country context, but we do include near misses as well as no harm incidents and harmful incidents or adverse events. So we use the minimum information model, and Maki has already referred to this, so I'm not going to go through that again. But we also use for our classification system for contributing factors, incident type, and incident outcome, we also use the WHO conceptual framework for international classification for patient safety, which we have also adjusted to fit our country context. We also do a severity assessment code, a risk rating for every patient safety incident, and you can see the 4 different risk ratings from SAC 1, which is our serious harm or death, to SAC 4, which is our no harm. We also included 3 indicators, which is also included in our national indicator data set, and that is the PSI closure rate, the PSI closure rate within 60 working days, as well as the SAC 1 reported to the next level, which is usually the provincial district office, within 24 hours. The implementation of the guideline is done through patient safety committees, which should be established at all the levels within the health system. So it's your health facilities, your provincial offices, your PHCs, and your district offices. These patient safety committees are responsible to develop their own policies, protocol, or guidelines that is in line with the national guideline. They must designate members for these committees that should be multidisciplinary, and they should draft terms of reference for these committees. We developed a web-based information when we published the first patient safety incident guideline in 2017. So the web-based information, we first have, we have a paper-based form that staff can fill in. Once they've filled in the paper-based form, the data is captured on the web-based information system. Our web-based information system is also compatible with tablets and cell phones. So staff do have the option, if they want to capture directly on the web-based information system, they do not need to complete the paper-based form as well. Once the data is captured for every patient safety incident, the data is auto-populated to generate reports and dashboards for registers, our indicators, as well as the various classifications. These dashboards and reports provide data for all levels within the healthcare system. So we used an existing platform that we use to do quality assessments for health facilities. And that web-based system is located at idealhealthfacility.org.za. We also have developed an offline module because many of our rural facilities do not have connectivity. So they do have the option to also use an offline module to capture the data. So if we just look at the progress made since we've implemented the guideline in 2018, we developed a compliance report on the web-based information system that gives us data on the percentage of facilities that have used the web-based information system. So this compliance reports we use as a proxy for measuring the percentage of facilities that implement the National Patient Safety Guideline. So you can see on the horizontal axis, all the 9 provinces is listed, and ZA stands for our country. So that's the country overview. So you can see between provinces, there are great differences, with some provinces have a 0% compliance rate and others have like a 93, 98% compliance, which just again emphasized to us that it's really about the leadership that makes a difference at whether systems are implemented. So you can see in South Africa on the far right column, we have a steady, we started with a 37% compliance rate, which then increased to 47. And at the end of 2021, we were at 51%. So our finding is that, since implementation in 2021, we ended with a 51% compliance rate. I am glad to say that currently for our financial year that has just ended, it looks like we will be ending at 64%. We unfortunately still have a very low culture of reporting patient safety incidents in our facilities because there's a huge fear of retribution and disciplinary action. We also noted when we did the analysis on the system that 93% of patient safety incidents that were reported by health care professionals. And we would really like to see that they also use other methods for detecting patient safety incidents, as we know that the literature shows that only 7 to 15% of PSIs are reported by healthcare professionals. Regarding the data quality, I also mentioned in the beginning that the staff really did not classify the incidents correctly, so the analysis did not make a lot of sense to us. They also did not understand the concept of what is a patient safety incident, so they would report incidents of standard care. For instance, if a patient with a gunshot wound came in, they would record that as a patient safety incident, even though the care provided was according to standard protocols. The description that was captured on the web-based information was also very poor, together with the findings and recommendations, therefore making learning at different levels within the healthcare system very difficult, as we could not understand what the PSIs were about. Because we instituted this compliance report for facilities, we realized that they are really focusing on just capturing and not really using the data to learn from PSIs that are reported. So our way forward, firstly, to improve our compliance rate for reporting so that we can have a complete national PSI data set. So we have been, since the system guideline was published, we sent out quarterly progress reports to quality assurance managers, and we also publish an annual report that is shared with provincial heads of health. And together with the compliance rate, we also need to make sure that what they are the data that is captured is of a good quality. We also have, we need to integrate other information systems that where also patient safety incidents are reported. So we have fragmented systems, as there are other systems for pharmacovigilance and maternal, neonatal and child deaths. We need to strengthen facility and district capacity to manage and learn from patient safety incidents. And so we realized that, at a lot of our facilities and provincial offices and district offices, there are not staff that are skilled in managing patient safety incidents. So we decided that from this year, we have developed an online training course for PSI management that staff then can access online. And we have also applied for continuous professional development points accreditation for those training modules. We also need to emphasize on learning and improving patient safety instead of making it just a tick box exercise to say, yes, I've reported or I did not report. And lastly, then we will still develop a national patient safety framework or plan using the data that we have collected. But currently, we decided that we are focusing on our PSI learning and reporting system to get staff to understand what a PSI is. So thank you for listening. That's then the end of my presentation. Nicole also asked that I give a short demonstration on our web-based information system. So let me just get out here. I just want to unshare. Okay, there we are. Okay, let me just share our web-based information system. Okay, there it is. Nikhil, can you see it? My screen.
Yes, I can see.
You can see, okay. So how our web-based information system works, and as I've mentioned, we've used an existing platform, which is our quality, basically our quality improvement platform, to add on a patient safety incident reporting and learning system. You will see in the URL, this is we also have a test site, which is a replicate of the live database. But because it contains confidential information, I'm using the test site, and we also use the test site to train staff to capture patient safety incidents. So in order to gain access to the system, you have to complete a user account form, and then an account with a temporary password is created for you. So in order to gain access, you just need to type in your username as well as your password. So apology, our network is a bit slow today, so please just bear with me. Nicole, can you still hear me? It seems that I lost.
Yeah, we lost your screen share.
Sorry about that. Yeah, let me just try again. Apology for that. Share. Yeah. Okay, there you are. Okay, so after you've typed in your username and your password, you will gain access to the web-based information system. So it's really a very simplified system. We have 3 tabs on top. Where your data management is where you capture. Your dashboard section gives graphs for you, and your reports is the reports on the PSIs. So you will see we have various modules. As I mentioned, this is only access for our compliance module and our patient safety incident module, but we also have access for hospitals and clinics to do quality assessments. So if you want to capture, you just select your patient safety capture site. You will see on the screen, these are already captured PSI. So if you want to capture a new PSI, you just select new. You will get a pop-up a text box where you then can select the facility that you want to capture for. Also to take note that when you apply for a user account, you must indicate for which facility you need access, or whether if it's a provincial office, you will request for the provincial office. We also capture some additional information which we find useful, like how was the PSI detected. You then capture the date that the actual PSI was identified. Depending on which, whether you choose a PHC facility or hospital, you will get a drop-down list for where the incident actually took place. You will see the system auto-generates a reference number. You can then select what type of PSI this was. Let's say this is a near miss, and we also record the time that the PSI occurred. You will see we've got many fields on the form, but only the fields that are marked with red asterisks are required fields. So we try to keep the data anonymized in terms of patient identification. So therefore only the patient file number is indicated as a required field. Our age we capture according to years, days or month. And you will see this is all the information that is required on the minimum information module. You will see that we've got some additional fields that's not compulsory that staff can complete. We also have free text fields where you must describe your summary of incidents, and we added some prompts to assist staff to capture the correct information there. Then we've got all our different types of classifications. So the first one is your contributing factor, and there can be more than one. So you can select all the different contributing factors. Then we come to your type of PSI, which you can then select, for instance, if it's a clinical process procedure error, you can, for instance, say this is a surgical error. We also have the outcomes classifications, which is part of the WHO classifications. So you can then select and say this is only moderate harm, and then we also classify all the different types of deaths. And you will see these deaths due to hospital-associated sepsis, thromboembolism is all part of the WHO advanced indicators in the Global Action Plan. You will see the form initially as red asterisks to complete the initial information. You will only be required to complete all the fields that has amber asterisks once the investigation has been completed. So once you have saved your form, you can go out, and then at a later stage you can return and go look up your PSI and just complete the investigation process and your findings and recommendations. You will see here you can access our dashboard. So unfortunately on our test site, the data doesn't look very interesting because we only have a few PSIs, but we do have graphs, both line graphs and bar graphs that gives information on the free indicators. And if you go down to the bottom, you will also see that we have dashboards for the patient safety incident, the different classifications, the type, the outcome, as well as the organizational outcome according to our 9 provinces. And on every dashboard and report, you've got these different filters where you can filter for a specific province or a specific facility, and also the year date. On our patient reports, you will see we've got facility-specific reports, which is our PSI register and this monthly statistical data report. And then we've got aggregated reports that gives information per level within the health system. So a national overview, provincial, district and sub-district, and facility overview. If you generate the reports, it generates in an Excel format. So if you want to edit on it, you can also do that. So I'm going to stop here just for now. Thank you, Nikhil.
So thank you so much, Ronel, for showcasing us this best practice from South Africa. And if we kind of connect it with what conceptual framework Maki presented earlier in the session, we can get a full kind of idea of a full package of reporting and learning system. And it's not only theory, it can be implemented with a WHO framework and can be of very much good for patient safety. Moving to next, now I will invite Dr. Jian Srivastava, who is from Quality and Patient Safety Division of National Health System Resource Center. It's a technical support institution with Ministry of Health, Government of India, and has been kind of pioneer in implementing patient safety and quality of care programs. And he will be showcasing and discussing about what we are focusing very much in the strategic objective 7 also of the Global Patient Safety Action Plan, how to embed patient safety being a cross-cutting theme into different public health programs and schemes. So over to you, Dr. Srivastava.
Thank you, Nikhil. And at the outset, I'm extremely grateful to Dr. Aparna and WHO headquarters, Dr. Neelam and the team for giving this opportunity to showcase, to share whatever we have been doing in a diverse country, large country like India, where we are not dealing with one health system. There are, in fact, total 36 health systems in the country. I'm talking about all the states and UTs. And with this diverse background, though the basic approach of the country remains based on the health systems approach, but since last couple of years, after say during last 5 years or so, after this conversation, global conversation on the patient safety started, and the patient safety became one of the focus area globally, led by WHO headquarters, then we thought that let's try to do whatever we can. And within that perspective, in fact, National Health Mission, we must realize the limitations are the boundary line. National Health Mission basically works with the states and mainly focused on the secondary care and the primary care health facilities. Though in the country, we have many tertiary care institutions, we have many non-government institutions and the systems. So as of now, our focus has been on these things. Within that, in the health systems approach and the programmatic approach, the health priorities for the country has been looking at life cycle approach. And in that context, the key priority for the country has been, starting from the reproductive health to the end of life care cycle approach. And within that, during last 4, 5 years, 6 years, we have tried to strengthen our existing framework, then to address specific needs and to ensure that our mothers, those who have delivered, newborns, strengthening the care around the birth, they receive the safe care. The Laksh initiative was launched. In addition, for the pediatric population, we have the Muskan. And of course, now the government has taken a decision that 150,000 odd health and wellness centers would be functional at the grassroots level. They are the primary vehicles to deliver the primary care for the 12 service packages. And there is a challenge also over there that if at the grassroots level we go, how do we ensure the safety in the primary care? And I will be sharing that work. In addition, for the adverse event following immunization also, we have done some work. So this is this slide shows that
We can't hear you, Dr. Srivastava. Oh,
I'm sorry. Just a minute.
We can hear you, but if you can come a bit close to your mic, so you may be a bit louder, maybe.
Okay, is the Nikhil screen visible?
Yeah, screen is always visible, yes.
And it is with the problem with the sound. Now is it better some way?
Yeah, but there is a bit of hissing noise, but maybe because of the microphone or something. Please continue.
So this is the complete spectrum which we have in the country. That one side, traditionally, we have had the ISQA accredited quality standards, and on instructions of the ministry and our governing board, we have strengthened the patient safety component in that. Then we have the Kayakalp, which basically talks about improving the work environment, strengthening the biomedical waste management and general waste management, strengthening the infection control practices. Then we have another side, the Muskan initiative. And in fact, when there was a change in the government recently, last year in the middle, and we went to Honorable Health Minister with the scheme for strengthening the services for the pediatric population. And he was looking at the things which we had incorporated in our guidelines, got so convinced that he decided that let's launch it on World Patient Safety Day on 17 September 21. Just a couple of months earlier, this initiative has been launched by the government. So the short point I'm trying to make is that the government has taken multiple steps within the existing framework. Besides this, the other efforts are going on, like I've been hearing with the keen interest, South African experience by the previous speaker, and also by the giving the overall framework by Maki, that coming out with a reporting and learning system. So within the existing framework, these things have been included, like safety for the patients, for the healthcare staff. Though I know many colleagues, they articulated their concerns. Many colleagues from India articulated their concern that about the increasing violence. But the focus has been that how do we create a safe and enabling environment for a healthcare worker, and also to create a blame-free or moving away from the blame culture. Then structural safety, infection control practices. This year, we are very happy to note that medication safety is one of the core area where the World Patient Safety Day in the month of September, and around that, many multiple activities are will be taken. But within that, we have built upon how do we manage LASA, look-alike, sound-alike drugs, or the rational prescribing. And within that, in fact, Dr. Sangeeta Sharma articulated the need of the clinical audit. But let me share with you that about 800 odd district hospitals, secondary care level facilities, which are about say 200 beds, 300 beds, even 400 beds are there. Then the safe surgery checklist, safe childbirth checklist have been already included. Safe nursing care, more so for the high risk and vulnerable patients, and radiation safety. In addition, for the AFI point of view, the reporting and causality assessments have also been included in the country. So if I look at from the spectrum point of view, on the primary care side, our focus has been in building the protocols for the safe prescribing of the medicines, because let's imagine that this field level functionary is working all alone, and there's for the palliative care, there's a substantial amount of the care which gets delivered through the ambulatory means. So that is a concern. Then for the NCDs, which are the global burden, and so is the burden for the country, where the patients are not being followed up that frequently. How do we ensure the self-medication counseling? These are the elements which have been already built into. Then maternal care, as I mentioned, the Laksh initiative takes care. And in the child care, we have got, particularly attention have been paid to the high alert drugs and also for the immunization, adherence to the open vial policies, and similar things have been undertaken for the secondary care facilities at the district hospital level. So in addition, like existing framework, also there are certain key performance indicators for each level of the facilities, which are being reported currently through the portal of HMIS, Health Management Information System of the country. In addition, for the safety and quality, we are coming out with an dedicated portal, and which will have the dashboard where all these indicators are expected to be reported by the facilities. In fact, the prototype has already been developed, and we expect that this thing should be launched within, say, 5 to 6 months of time in the country for all the states which I mentioned. And India, as I mentioned yesterday also in my passing, that India has been one of the countries where we launched the operational, National Patient Safety Implementation Framework. And currently the work is getting concluded in coming out with the certain operational guidelines for the National Patient Safety Implementation Framework, where we want to provide small doable steps for our peripheral health facilities. Because let us imagine that in the primary health center, which are in the country about 25,000 odd, and urban PHCs, there is hardly one medical officer, 2-3 nurses, they are available, but we are not leaving them. And we want to bring everybody on board. And under the existing framework, yesterday, in fact, after hearing all the speakers, we thought that let's try to look at how we have been doing as such on the certain safety parameters in the country in terms of the secondary care facilities. And you will notice over there, in fact, this is a very interesting finding which have come out, that if I look at the, many elements of the blood safety, the compliance has been varying between, say, 80 to 95%, which is fairly, I would say, the satisfactory. But on certain dimensions, we need a lot of ground to cover up. More so these newer things which are coming up in the horizon, like risk management, where the score is about, say, 50% to 70%, depending upon the state and type of health facilities. Then, I fully correlate with our nursing colleague, Madam Gomez, who brought out the need of involving, which were in fact echoed by Dr. Sangeeta Sharma also, bringing the nursing professional on board. And we are looking at the score, which is between, say, 45 to 83%, tells me that we need to be doing a lot of things in this direction. And implementation of these things requires whole lot of efforts at the national level, at the district level, at the, in fact, the facility level, and at the state level. And the whole endeavor had been that is starting from governance to the finance. And also now we are, in fact, in our training programs, we are sensitizing to the policymakers, to the health managers, to look at the ergonomics aspects as well. In fact, the element of the ergonomics have been built upon very intensively in the latest IPHS guidelines, which the country has, in fact, the country has revised and launched on 16th of this month only, just a couple of days earlier. And so at the national level, we have the National Patient Safety Steering Committee. At the state level, the states have been told to constitute a subcommittee for the patient safety, and at the district level and at the facility level. And these are not the committees all alone. These committees are manned by the technical manpower who are providing the technical assistance to the state, to the functionaries, so that they also start looking around these things. Yesterday, after listening to Nikhil's presentation, we thought that let me just look at that. As a country, how are we doing in terms of those 7x5 matrix? A caveat over here, this is my own perception, which I felt that where do we stand? Some of my colleagues can always challenge me or counter, and certainly an official version will follow. So on certain elements, the situation is not too bad, which is being shown in the green color, green bars. But on the red, whatever is shown in the red format, certainly we do realize that a lot of ground needs to be covered up, and we are fully aware and intend undertaking the actions. On those things which are shown as yellow, I mean, some action have been started, but we need to be doing more of the ground. So just to sum up, that like we have a national quality assurance standard, Kayakal, Plaksh, which I mentioned in the beginning, and the Muskan, and this all dimensions towards whatever is, required to be done and what is doable. We know that we are making just a beginning. Many things are unattended that we intend taking it forward, and patient safety is fully grounded in our country's UHC agenda, because one side the government is committed to reach out to the communities, and another side we have incorporated within that. Kayakalp is one initiative which in fact received global attention also. It was well appreciated in the World Health Assembly in 2019, and since then more number of facilities have come on the board of the Kayakalp. And these are the couple of the glimpses. This is my last slide, where you can see that on the World Patient Safety Day and otherwise also multiple activities depending upon the need of the system, depending upon the need of the health facilities, which are being undertaken, starting from the illumination to the oath administration and multiple activities. So once again, thank you very much. And we believe that safety is everyone's responsibility. Thank you.
So, thank you so much, Dr. Srivastav, for showcasing and sharing the best practices what India NHSRC is doing for embedding patient safety in different public health programs. And now I will invite Professor Koh Khian Tan, who is the Group Director and Associate Dean at Singh Health in Singapore, Institute of Patient Safety and Quality. And he has been a speaker in a lot of our regular speaker in a lot of global and international meetings and consultation we organize. And over to you, Professor Tan. He will be talking about how to implement patient safety at the healthcare facility level. Thank you. Over to you, Dr. Tan.
Yeah, thank you, Nikhil, for your introduction, and thank you, the organizing committee, for inviting me. I'm very happy to share some of our experience in Singapore in relation to global patient safety. So as you know, Singapore is a small country, 5 million. Our maternal mortality ratio is 8 per 100,000. Life expectancy is 83.9 years, and we spend about 4.5% of our GDP on health expenditure. We have an infant mortality of 1.8 per 1,000 live birth. And our public healthcare system plays a very important part. It provides subsidies for services and drugs at our public hospital, specialist outpatient clinic and polyclinic, to ensure access to more affordable care. And I'm from, there are 3 clusters. I'm actually from the Singh Health cluster, which is the largest cluster and is the east. And our flagship hospital is the Singapore General Hospital. So I must thank actually Dr. Neelam and all her WHO colleagues for bringing this superb Global Patient Safety Action Plan framework. This is truly remarkable because it actually sharpened our focus on global patient safety, how to put forward patient safety, collaborating with everyone in the global setting towards a better outcome. And it's focused, which rightly so, on eliminating avoidable harm in healthcare. In fact, it is a boost for our patient safety culture and a reference for all our Singapore healthcare cluster and facilities to do better, to fine-tune and to share practice with each other. It will also help us to promote organization learning, because these 7 domains are quite easy to grasp and it's quite systematic. And if we are able to look at what areas that we need to focus on, with the tighten up, and also to share with others if we think it's a good practice. So the first one relates to the policies to eliminate avoidable harm. And here, fortunately, in Singapore, we have a legal act that actually allows that to do it very well. We have this Private Hospital Medical Clinical Act, which was later amended to the Healthcare Services Act. And this act gives actually legal protection for members and for the findings for the Quality Assurance Committee to review serious reportable events. So as you hear from the South African colleague about reported events, at the national level, we report only serious events, and we do it in a very serious fashion because this will be analyzed and so-called shared with all the rest of the other cluster. For those near misses and those minor patient safety incidents, less serious, we report it at the institutional level, and we have thousands of that, and it's usually done electronically. But for the serious reportables, we do it at the national level. The MOH provides the opportunity for cross-sharing of the learnings of these serious reportable events. So we have actually about 31 categories, and we modify on and off. This is the list from 2013, and we have actually modified a little bit to some of them to exclude falls if it's not causing serious injuries, because we wanted to analyze those that are pretty serious and it should not happen, at least in Singapore. And we try to reduce it to the avoidable harm. So there are 31 categories, ranging surgical events, medical device event, patient protection events, environmental events, care management events, and radiological events, right? And then we will have a very structured way. There first will be a notification within a certain time period, and we will have to do a root cause analysis, to do a review, and we will have to report this root cause analysis in this full format to the MOH. And the MOH will actually have a notification officer who will actually look at how we are following up. So on and off, if we say we are following up at 3-6 months, they will ask the institution who have submitted whether they are doing according to the action plans. So this is something which I was very happy about, because recently for the the last couple of years, they have started to put in digest in the form of a report. So every quarter, the trend will be stated. There's a drill down of the categories of SRE. The RCA findings and root causes and recommendations will all be in this particular spreadsheet itself. And the insight shares will be put as updated patient safety tips. And at the same time, there will be regular public bulletins on the digested learning as well. And this is a very useful thing, because I think the reporting system, the most important thing is able to learn from it. And we're doing it at a national level, focusing with very high quality RCA. At least we want to have very high quality RCA. Right. At the so-called cluster level, patient safety is our priority. A safety culture to avoid, to reduce avoidable harm is important, and this is part of our ethos as well. In fact, at our CEO CMB meetings chaired by our group CEO, this is reported on a quarterly basis, on a regular basis. And what we are looking at is whether our leaders, are doing patient safety walkarounds. In terms of serious reported events, near misses, how many there are, audits and assessment, whether there's patient safety programs and other engagement like patient safety awards, patient safety index, clinical excellence indices, and patient safety sharing. This is not a competition, but this is actually, where all the leaders of the institution, we have about up to 11 institutions, all the CEOs and CMO come together to share patient safety story, as well as to discuss about their engagement with patient safety. And leaders need to walk the talk in patient safety. So they serve as a role model for the rest of the institution staff to follow. At the same time, the institution will share all the policies in ensuring high standards. There'll be comparison, harmonization, looking at various aspects like infection, medication, clinical privileges, patient assessment, various aspects of policies relating to this patient care. Very important to have high reliability care. We need to have robust process improvement. We need to strengthen the system we need to have strong leadership commitment and a good patient safety culture, as well as to share the best practices. So we adopted this model, which is from JCI. Basically, is that stressing leadership commitment, safety culture, robust process improvement within this particular framework to achieve high reliability, right? So recently at our, maybe about within these 2 years or so, we have gone beyond the JCI accreditation framework. In the past, our public hospitals are all accredited by JCI, but we have dropped that to form our own framework, ensure safer system framework. The main reason is that we felt that, JCI is like an exam, but we want continuous improvement. And also we want to localize the standard to our own country. At the same time, we actually also engage JCI with us to look at how we can actually improve our system better, which is actually focused on high reliability again, leadership commitment at all levels to zero harm, safety culture, continuous process improvement to be able to do that. At the same time, we also support within the clusters our cross-institutional surveys, audit and assessment for the safer system. So this is a chart just to tell us that in order to have good patient safety, you really need to improve a lot of desired cultures and mitigate the counter cultures. And I think today, all of us said about reporting culture. Our reporting culture must be strong. It should not be, blaming each other for that, but it's strong. At the same time, there should be a good support culture for people who are affected, safety culture, resilience culture, just cultures, learning culture, speak up culture, very important. And we take every opportunities within our institution to actually have this, to promote this ethos of strong safety culture, including using a advocacy pledge for patient safety. So as I mentioned about this PACER, which is our patient safety evaluation report itself, we look at how we are doing on all these five categories with 13 indicators. And as mentioned before, the SRE, we try to do it as good as possible. As you know, there are many standards of SRC, so you really need to teach people how to do the root cause analysis for the SRE well. So we have assessment to see the strength of the RCA, the quality of the action plan as well. So very important to be able to enhance the robustness and effectiveness of root cause analysis when we are doing the SRE. Because if you have very weak RCA and you don't do it well, the learning, the insights that you gather will be much less, and it will be less useful. Of course, we believe in both quality and assurance and also quality improvement. So besides eliminating avoidance harm using RCAs, a very important aspect is to have the improvement mindset within the cluster, within the institution as well. That relates to our Global Patient Safety Action Plan of the assuring the safety of every clinical process. That's domain 3, right? So it's important to identify all the risk-prone procedures, all those clinical procedures that have a lot of risk of complications and able to improve and mitigate their risk and improve the outcome. So basically what I'm trying to say is to adopt an improvement mindset, to be engaged in the process and to be able to co-create solutions with all your partners, including patient. Right, so we also, around this time, we also have a new national governance structure because we felt that we need to be more focused about improvement. And under this National Improvement Unit, we have the National Health Outcomes Council in Singapore, the National Performance Steering Committee, to facilitate the improvement at the national level. And as I said, we need to prioritize. So the first is actually the diabetes, which is a very huge population problem, causing a lot of sort of bad health outcomes. And next, we will look at hospital-acquired infections and also the mental health dementia collaborative. So I just show you some of the things that we are thinking about. Basically, we are adopting a large collaborative kind of framework, which we have actually learned from IHI, called the Breakthrough Series, Share, Learn, Sustain, and Spread. So there's, while we are doing this collaborative, there's a lot of leadership support. There's also a lot of people sharing learning lessons. bringing out together team to work on the specific challenge for a short period of time, usually 18 months. So this is the DM collaborative measurement strategy, pretty important because when we analyze Singapore in terms of our diabetes outcome is actually, for example, the admissions rate is actually twice that of the OECD average. And we felt that perhaps there's an opportunity for improvement. So we break it into various aspects, like effective disease management, integration of the primary, acute, and community management for the management of complication. This is one of the weaknesses where we are unable to integrate it well, and also managing the risk of the admissions and readmissions of the frequent admitters. So this is the primary and secondary driver. I won't go into them in detail, but I will be able to share you the slides relating to that to reduce the diabetes admission rate and of course the complications relating to diabetes. We want to have good HbA1c control. We want to reduce reattendance, readmission. We want them to be managed well. Right. At the cluster level, we also very focused. We have clinical excellence categories, for example, that hand hygiene compliance rate, environmental hygiene compliance rate, inpatient fall rate, MRSA, bacteria. So these are some of the things we do. We also don't forget the 6th most important, which is the international patient safety goals. So a lot of our institution so-called work relating to trying to improve care works around these 6 goals, which is very important. And I'm sure you know this, I won't go into detail about this. And of course, we have a very strong framework for QI. So we have a system that helps to facilitate a lot of QI programs within the institution and the clusters, right? One of them is actually the domain is called where we did is on the catheter-associated urinary tract infections. And we are actually looking at patient care, training competency, patient education, policy supplements, in putting a bundle to reduce the CORT. And we actually achieved a lot of success in a couple of institutions, and we are promoting a cross-institutional kind of spread. So we have projects called Ground Up, Reach Up to Skill. We want to skill the project, which we call gurus. So a lot of gurus in SingHealth doing all this work to scale and to spread. Yeah. Okay. The other thing which find difficult, and I think a lot of Asian countries, hospitals find difficult, is trying to get the patient on board. We always think the patient is quite passive, but we were pleasantly surprised when we started our SingHealth Patient Advocacy Network we call SPAN. And this has taken on a life of its own. With the patients actually just superb. If they are given a certain framework and if they are led among themselves, if some of the leaders, they can actually do marvelous work complementing, promoting patient safety as well. So the mission, vision, core values, these are actually they themselves, within the group, their leaders, they come to a meeting and they actually come up with this mission, vision, and core values. Of course, some of us are advisors, but they actually do almost all the work itself. So we actually started this also recently, and we're quite happy to say that it has gone on very well. They have done a lot of work. They are even invited to national large-scale dialogues. They participate in the Asia Pacific Patient Congress. Kamaljeet Singh would know about this. And then they also co-presented at the annual IHI BMJ conference, including doing a lot of activities. So this is them supporting, our staff in doing our work itself, a video to thank and cheer on our healthcare staff during COVID. And then here again, is they write to the national press, telling us, telling other people to be kinder to healthcare workers itself. So, and you can see here, healthcare workers say no to abuse and speak up for them. That is written by our SPAN itself. And nothing is as powerful as the patient speaking for the healthcare workers. This is in the list of one of our institutions, right? And the other thing relates to the healthcare workers. I think it's important, as all of us know, to inspire, educate, skill, and protect and support our healthcare workers to contribute to their work. And that's why it's important to expand their competency with various programs. I'm very happy to note that we now have a staff career development pathway for patient safety and quality staff. Those staff who want to that as well. But of course, for all staff, we've tried to provide them with the necessary so-called programs to that. We did a survey. We found out that, like 37.8% of our staff was burned out. We were quite shocked, but then we only maybe consoled by the fact that it's actually an international phenomenon. So, but nonetheless, I think we need to be able to reduce the burnout of our healthcare workers, not only just in SingHealth, but in nationally and internationally as well. Which is why we also look at some of the framework, the IHI Joint Work Framework, and we crystallize into this 9 components domain to ensure a joyful, thriving, resilient staff, people. As you know, in order to do this, you need a multi-pronged approach and a need for prioritization. You need to give your staff meaning and purpose, appreciation and recognition, choice and autonomy, physical and psychological safety, and various things, in order to be able to make sure that they are able to find joy at work, and they will be less stressed out. So we actually have various programs that we have actually crafted. I think if you want to know, I can tell more, but basically all these programs teach resilience, communications, self and team care skills, and promote shared ethos and positive behavior. For example, Team Speak is promote a positive behavior of speaking up for patient safety in our healthcare. Coming to the last 2 aspects, one is the information and the research. We need to ensure that it's a constant flow of information and knowledge to drive the mitigation of risk and the reduction in avoidable harm. So this is our flow and governance within SingHealth. We actually separate them into 3 categories. One is the risk, one is the clinical governance, one is the QI, and they all have information flowing through, and we synergize in order to make a good flow for that itself. And we also have various experts, which we group them into various work groups. There's a medication safety work group, infection prevention, procedure safety, force prevention, and now even a data and cybersecurity work group, because IT is security is also a big issue as well. And then we are able to process the information, put it up into a heat map to see what areas we need to pay attention to, and to do a enterprise risk management review. And finally, the last aspect of the GPSAP is about trying to develop and sustain multi-sectoral, multinational synergy, partnership, and solidarity to improve patient safety and quality of care. So in SingHealth, we have the ESTER network, which should promote the philosophy of patient-centered care. And they have a whole group of partners, both in the institution, within SingHealth and outside the institution, to look at so that they evolve from person-centered care to population-centered care. We also have a SingHealth community partnership, and we have various programs. So one of them is Neighbors for Active Living, because we think that it's a better bet to depend upon your neighbors rather than your distant relatives for help when things goes wrong medically. And we are able to show some decrease in number of admission itself. I just want to say just 1 or 2 slides relating to our COVID. And we are very pleased that our Prime Minister, Lee Hsien Loong, actually spoke just about 3 days ago in SGH, in our hospital, about our COVID experience. He paid tributes to our healthcare workers battling the pandemic. And he says that we must not let valuable lessons go to waste. And the journey for Singapore has not been easy, because we are, we have to quickly adapt to the various situations, imposing circuit breaker, multi-weasing, tightening, implementing contact tracing, trace together, procuring supplies and everything. But what actually makes Singapore pull through and have such a low fatality rate is basically what he says is a resilient healthcare system, effective public health response, and very importantly, a high degree of public trust and commitment among public, community partners, and healthcare institutions. And he urged us that to further improve the trust for healthcare system, we need not only the competence and commitment, but we need to have transparency of the healthcare system. So doing things like root cause analysis and sharing it, and able to also tell the public that we are doing something. So very interesting is this just goes to show that we need to be able to keep our standards high, develop public health expertise, and to build a high degree of trust with our Singaporeans. So this is very important to do that. So for example, you mentioned that regularly reporting statistics on serious adverse events following COVID-19 vaccination and proactively investigating any errors, such as when someone received the wrong dose, which you have done appropriately. Also like to share that we have also done something regionally. We have a GALLOPS, which is the Global Action for Leaders and Learning Organization Patient Safety, where there's about 136 regional participants from 16 countries. And we actually done some kind of analysis after they have gone through about how they self-assess that. I think just now previous speaker was self-assessing about India. And we have an interesting chart here. Basically, this is the first 6 centers that actually responded to our assessment. Red means there's opportunity for improvement. Green means they think it's best practices. As you can see, there different centers rate themselves, assess differently as different. Some of them thinking that they're more good practices. Some of them think that they need to learn a bit more itself. And you can see a sea of red here. That is relating to healthcare workers itself, right? As well, relating to patient safety education, and that might be a indicator that for these centers, it would be an important priority for them, right? So the whole purpose is that if we can share good practices and practices for improvement, we are able to adopt and adapt and contextualize all our practices so that we can help another center be able to progress in patient safety. So that's all I have to say. Thank you very much for your attention.
So thank you so much, Professor Tan, and also to Dr. Srivastav and Ronald for being excellent communicator and presenting on the best practices. Certainly, I think the programs, these flagship programs like Muskan and Gallup and JAW. So I can see a lot of one good thing also we can understand from we can get from these programs that it's important to design, but also to present and package programs in an interesting way. So there is a acceptability down the workforce. There will be, of course, certain questions on these presentations. There will be a lot of queries. We are just running a bit short of time. So we are not kind of abolishing this Q&A session, but we are just postponing it. So first we keep the last 2 presentations because those are very important, and because of the time zone difference, so some of the participants may feel a bit, it may be a bit late for them. So we will keep all the queries and interventions for the end while we will be concluding this consultation. So now I hand over to Dr. Aparna Shah for the next session. Over to you, Dr. Aparna. Please unmute yourself. We can't hear you.
Hello. Hello. Okay. So thank you to all these speakers for their excellent presentations. Since we are running short of time, as Nikhil rightly said, we cannot take QAs now. Having said that, it shouldn't prevent audiences writing emails to all these speakers, and then they will respond to their queries. So now we are moving to session 5, that is monitoring and reporting for patient safety implementation. So first talk is by Nikhil. It's about patient safety indicators, surveys, and reporting to World Health Assembly 2023 and beyond. Over to you, Nikhil. Thank you.
Okay. So I will be talking about the monitoring and reporting on the progress of Global Patient Safety Action Plan, specifically because it is having a implication on the World Health Assembly for the next year also. So we'll be very focused. I'm not going to talk about the overall measurement of patient safety. We can talk about them in a more kind of a maybe in a dedicated session, but being more focused on the reporting requirements to the countries, to the member states, on the progress of Global Patient Safety Action Plan. And this is coming from two sources. One, the Global Action on Patient Safety, WHA 72.6. It itself, the resolution from where we are having the mandate for action plan says that submit a report on the progress of the implementation of this resolution, the Global Action on Patient Safety, for the consideration of 74th, 76th, and 78th World Health Assemblies. So 74th, the last year we submitted our progress on the assembly, and the same assembly we got approval on the action plan also. Now, when we got the approval for the action plan, the assembly also requested Director General and the member states to report back on this action plan also that has been approved every 2 years, starting from 2023. So the next year, Assembly, World Health Assembly, usually due in June, May or June, we have to report on the progress of this action plan. And what we have to report, there are certain parameters, those have been defined in the action plan itself. And I'm going to just present on those parameters and indicators. So this is kind of the process flow, how we are planning to do it. Some of the part is already being done. Kind of we are defining metadata and survey tools. It is in very kind of advanced stage. And then we'll be reaching out to the member states, to all the countries, to give their status on the indicators and the parameters of the Global Patient Safety Action Plan. And this will be then analyzed and will be reported to the World Health Assembly next year. And it's not only one time, this will be done every 2 years after 2023. So what are the goals of this program is to have at least some kind of a minimum set of core indicators and parameters by which we can ascertain that how we are progressing for global action on patient safety. And these are some of the general principles. Just for the sake of time, I'm directly coming to the crux of the reporting. There are certain indicators, those have been mentioned, have been defined in the Global Patient Safety Action Plan. Those who have read the document might have seen those indicators, or you can look into those indicators. So there are 10 core indicators, and then there are certain advanced indicators. So these 10 core indicators are mostly the system level indicators. Those has to be reported by countries on biennial basis at least. And the advanced indicators, those are also applicable at the system level, and some of them are at the healthcare facility level. For those, the countries and the systems are free. They can prioritize, they can choose some of those indicators. Those are most relevant to them. But these 10 core indicators are a minimum that has to be reported. Based on these indicators and the report we will get from the countries, we will submit it to the World Health Assembly. And there is also a plan to release a global patient safety report that will be kind of a snapshot of the affairs of global patient safety in 2023, and then it could be kind of a subsequent regular publication every year. So these are, as I discussed, these are the core indicators are more policy and programmatic indicators at the country level. And these are those 10 indicators, core indicators. These are very much aligned with the strategic objective of the Global Patient Safety Action Plan. So as you know that we have 7 strategic objectives, and these 10 indicators, core indicators, are kind of tracers or kind of a representative indicators for understanding what is the progress on the recommendation of a certain strategic objective. So I would like to kind of at least present these 10 indicators, and very much these are very much easy to report, except some of them that may require some groundwork. Like strategic objective 1, the indicator is number of countries those have developed a national action plan on patient safety. So it's a qualitative indicator, and it could be reported by member states and I think without much groundwork. But of course, this for reporting positive, we have to develop a national patient safety action plan at the country level. Like strategic objective 2, the indicator is number of countries those have implemented a system of reporting never events or sentinel event, what Professor Tan was just presenting as serious events in Singapore. So the nomenclature may be different, but the minimum requirement or minimum recommendation is that at least for serious patient safety events, we should have a system of reporting. And when we are saying reporting, of course, analyzing and taking action on those. So that's for strategic objective 2. A strategic objective 3, that is on clinical care, we have 2 indicators. One is on hospital or healthcare associated infection. So there should be a significant reduction in that. Now, what is significant, that we leave it to the country, that they should measure their baseline and can set a national target that this much we will reduce in 2 years. And what we are observing at the global level is whether the country has met their own set target or not. We haven't given a figure here, but at the global level, because it will be very difficult to put a figure, because a lot of countries may not even have a baseline, and they may be at very different stages of how they are tackling hospital-acquired infection. The second indicator, that is again a clinical in nature, is about medication-related harm, a significant reduction in the medication-related harm. This is also the indicator and the goal of the WHO third Global Patient Safety Challenge, medication without harm. And this we are measuring. For these 2 indicators, of course, we need to have some groundwork at the system level, at the hospital level, because if we are not getting information on these indicators from the hospitals, it will be very difficult to report to the global level, even at the national level. Now coming to the strategic objective 4, which is about the patient engagement, the indicator is very straightforward, that how many kind of countries have most of the hospitals where they have at least one patient representative represented in the governing board of the hospital. When we are saying majority of hospital, we are saying 60% at least. So 60% of hospitals in a country should have, we say 100%, but at least meeting kind of majority, we are saying for quantifying, we are saying 60% should have a patient representative in the governing board of the hospitals. Strategic objective 5, Dr. Reena already presented these indicators. I am repeating. First one is regarding incorporating patient safety curriculum in the education programs and courses of healthcare professionals like doctors and nurses. And another one is number of countries those have signed up for the Health Worker Safety Charter. Strategic objective 6 is about what we discussed today in multiple presentation about patient safety incident reporting and learning system. This indicator is about that countries should have a patient safety incident reporting and learning system, and having only doesn't suffice. Most of the hospitals, again, we are seeing at least 60% of the hospitals should be participating in this national reporting and learning system. We are saying national, but maybe in a large country, it may be at the provincial or at the state level also. But the intent is to have operational patient safety reporting and learning system. Objective 6, we have another indicator about whether an annual report on patient safety has been published or not. And strategic objective 7, we have an indicator about national patient safety network, whether it has been established in the country or not. So these are the 10 indicators. These are again illustrated very well in the Global Patient Safety Action Plan also. And we are planning to at least get status of where the countries are for reporting to the World Health Assembly in 2023. I will be coming to the timeline when it should be reported. But those who are kind of in the Ministry of Health and kind of directly in the communication with WHO country offices and regional offices might be knowing that the regional office has sent us kind of a quick survey on certain points. Those are very much aligned with the regional as well as the global patient safety action plan for getting information on the status. So this will, the survey that I will be going to present now will be just complementing and kind of getting more updated information on what regional office is already doing. So like this is a snapshot of one indicator, and with the indicator, like say this one, the first one on the strategic objective, we have set some global targets, and these global targets are based on the consultation we had while developing these indicators in Global Patient Safety Action Plan. Now, these are kind of an overall global sum of average of the progress, but at the country level, at the national level, you may put your own kind of target for these years. Apart from that, as I told you that we are having some advanced indicators, like I'm presenting these indicators, those are for strategic objective 1. And like these are strategic objective 3 on the clinical care, where a lot of indicators on the hospital-based care, like perioperative mortality or venous thromboembolism, AMR and VAP, all these indicators are there. We haven't made them kind of core indicators, though some of them are very much critical to patient safety, because the capacity and the priority in each country, in each hospital will vary based on what kind of a care they are providing and what is their priority also. So these indicators are listed in the action plan. What we will suggest that when we are drafting the National Patient Safety Action Plan, or when we are having the first meeting of on responding after this session, this consultation on the Global Patient Safety Action Plan, we can have some discussion internally at the country level, even at the sub-national level, that what are the indicators, those are most appropriate to be measured in the first core. We can make a priority also. We can take some of the indicators from these advanced indicators, the first go, see how they are behaving and how kind of relevant and what kind of a quality of data we are getting on these. And then we can later on add more indicators on the list of what we wish to measure. So what we are going to do is we are developing a survey tool, assessment tool from the global level that will be shared to the ministries of health from the appropriate channel of regional and country offices, WHO country offices. And this will be coming to you later in the year, maybe around July or August. And we will request you to fill this survey. These questions, this is kind of a more a maturity matrix where we can also score kind of a country or even a hospital based on the different attributes. Those are written in the Global Patient Safety Action Plan. Again, this is all aligned with the strategic objectives and the 7x5 metrics of the action plan. And we'll be kind of, once this is out, this is in public, we'll be also helping the ministries and the countries through the WHO country office channel for capacity building and training how to report on these indicators and assessment tool. So that's all on reporting requirements for World Health Assembly. And now I hand over to Dr. Aparna. Thank you. Over. She's not there, then maybe.
Thank you, Nikhil, and apologies, I went out for a minute. So now we are coming to almost closure of this meeting. So now I would like to call Dr. Neelam for any comments she may have. Actually, she was supposed to make a presentation, but we are thinking of, just to save time, making it little brief. So I'm handing over floor to Dr. Neelam. Over to you.
Thank you very much, Aparna. So I'll keep it as brief as possible. And I think it's very important for us while we are concluding this consultation to look into the aspect of implementation. And Mahatma Gandhi mentioned that an ounce of practice is worth 1,000 words. So we actually have the action plan identifies the patient safety implementation ecosystem, which has action by government as well as action at the point of care. And I just want to highlight 2 points before we go to the conclusion, that when we are implementing at national level, we have to acknowledge the variation in countries and also within countries at different levels. So the structure, funding and governance, whether it's a public sector or private sector, not profit, or what is the overall policy objective, what is the maturity of the system, the resources availability, the culture and the general demography, and also innovations and transformation because of technologies. So just on this slide, I want to say there's a roadmap which I want to share with you of multiple milestones as steps in implementing the Global Patient Safety Action Plan at national level, and which relates to firstly landscape assessment and situation analysis, which includes mapping of all the partners, policies, as well as programs, and looking into how do we, and also the assessment of health facilities, and then really develop a program which is based on the real data, local data. Then secure strong commitment from political and organizational leadership through building a case, through identifying economic impact of patient safety interventions, also participation in summit series, as well as maximizing World Patient Safety Day implementation, developing a national plan with key stakeholders, and also adapting through an expert group, adapting the global plan to a national plan, establishing a sustainable mechanism for implementation by identifying a suitable nodal person at different levels, and also making sure that there is a mechanism like a committee or a task force which takes forward the action in a sustainable manner. And then align with national context and priorities, particularly related to where the highest risks are, where the interventions can benefit large number of population. And last but not the least, decide upon the design and the model of change for implementation so that we start small but make it incremental. So those were a couple of points I wanted to just share as part of the steps in taking forward and implementing the action plan at the national level. I'd like to hand over now to Aparna for her concluding remarks. Over to you, Aparna. Thank you.
Thank you, Neelam, and thank you for your excellent, very brief presentation. I mean, you said everything actually in brief, whatever I was going to say. So, a couple of points which I have written actually during this meeting. So, I would like to read these points. There's a need for policy, strategy, and implementation plan with timelines and a national action plan, mindful of multidisciplinary nature of patient safety. We need to have a committee which must be comprising of people from all the different disciplines, and it has to be, we need to take a multi-prong approach, and then there has to be a coordination center. We need to take integrated approach. It is very fragmented at the moment. Different programs are following patient safety, but it is not in one. So it's kind of thinning of resources and duplication of efforts. So at national level, there should be a coordination center. We should have political commitment that will give us annual funding for the program. There should be a very good data management system. We should have a very good incident reporting and management system. And if we have a good data management system, then only we can have evidence based documents, be it policy or the implementation plan. And we need to do the monitoring and evaluation on regular basis. We need to choose the indicators very carefully in countries context to see the progress. And as Nikhil presented and said that there will be a questionnaire coming for filling out. So one questionnaire has already been circulated from regional office. So once we collect the basic information, for you it will be very easy to fill in the questionnaire coming from the headquarter, the global portal, because by then you will be already having compiled basic information. So you will be building on that information. You will not start from the scratch. And then we need to have patient safety networks, and also patients for patient safety networks. So we need to have it at regional level. First of all, countries must have it at national level, and then countries must connect with each other to share the best practices and experiences. So there should be very good regional networking. So with that, I think this is all from my side, and I would like to ask our audience if they want to make any final comments from different member states. We now do not have many participants. We have now at the moment 52 participants. So any country if want to make any last comment, so I would like to invite them for their views and any request if they wish to make over to the audience. Thank you.
So there are two hands, Dr. Yeah, please go ahead, Dr. Gomez.
One small correction. I am not Dr. Gomez. I am Miss Gomez.
Okay, sorry.
Everybody tend to call me Dr. Gomez. Thank you. Just a small clarification from Dr. Srivastava. I am a totally corporate private sector person. I was not at all aware the quantum of work that India has achieved. I've heard a little bit about Kayakalp, but all the other things that Dr. Srivastava presented was new to me. So it was not known to us. So the question is 62% of healthcare delivery in India happens through the private sector. So how are we planning to incorporate them into the national statistics, data or surveillance or report that is going to go in, knowing that private sector has the largest quantum of delivery in India?
My quick response would be that if we are talking about the health system as such, we don't have to differentiate between whether it is for the the government system or not for profit or NGO or whatever sector is there. But at same time, fact also remains that the approach will have to be graduated one, And there is an immense role, which in fact we also talked with our governing board, which is headed by Health Secretary, that everybody will have to come on board. And we also received as a certification body for the Laksh norms and other things. But the governments, as of now, the focus is to strengthen the public health system for a year or so. And then subsequently, we have been told that gradually we will reach out to the private. And I mean, whether it is the private or government, both, I mean, everybody has got a diverse role. I mean, a definite role in a diverse country like India, and we have to come together. So it will have to be the graduated approach. That is my short answer.
Thank you.
Can I speak?
Dr. John?
Yes, thank you, Dr. Aparna. Thank you very much for all the hard work that all of you have been putting in to organize this consultation. As a clinician, patient safety is an existential crisis for all of us, not just for the patient, but for us as professionally also. So that's why these 2 days of deliberation has made a huge, I think, has a lot of meaning for all of us. My appeal would be to help this trickle down more quickly to the to the professional medical and surgical societies. I think they'll be good collaborators because patient safety is not a distinct, discrete activity. It's part of our mainstream clinical work we do every day, and this needs to start being brought in from the undergraduate level, inculcated in the curriculum rather than a standalone clinical activity when we reach hospital practice, so that it's inbred into the system. Otherwise, it stands out discreetly. It's a bit of a pain, to sometimes handle these issues, and people have a lot of anxiety and apprehension when they're faced with a patient safety issue. We need to start sort of accepting this as part of human activity. So, thank you very much for your hard work, and I'm learning to be more sensitive in the way I educate people because as humans, we are born to err. Thank you very much.
Dr. Nima Sangye from Bhutan.
Good afternoon. Good afternoon. I have only one question that in regards to patient safety, the public don't want to complain or don't want to give a written complaint to the regulatory authority, but they complain in the media. If the complaint appears in the media, do the regulatory or professional council has authority to investigate with regard to the patient safety? Thank you, Doctor.
Neelam, do you want to take the question?
Sorry, I actually have to sign off for another important meeting. So maybe if you can repeat the question for me, I would appreciate.
One question, please. Yes, my question addressed to Dr. Srivastava, please, regarding medication safety, especially injection safety. What we have seen in injection labeling, the very small ampules, that you cannot read this expiry and manufacturing date. It becomes very difficult to read the manufacturing expiry date, and that becomes difficult for the nurse or the doctor to give injections. So anything can be done regarding labeling of ampules specifically.
So there is, in fact, the scope is huge. But like we all know that in India, the drugs, manufacturing of the drugs is being controlled by a different ministry, different department altogether. While on the health side, we are responsible for using those drugs in a safe way. That also remains a challenge. So we are in conversation with them to do something about the labeling, particularly address the issue of the LASA, look-alike, sound-alike drugs, and at the same time, also for the critical drugs, which have a huge potential to cause the harm.
Specifically, I'd like to address the transparent ampules, because some ampules have paper label. That's okay. Still, one can read that. But for transparent ampules, it is very difficult. At least health secretary can coordinate with the chemical secretary, and this can be sorted out.
Thank you for highlighting this issue, which will certainly give a boost to this.
Thank you, sir. Thank you.
Can I make a point?
I think, yeah, please, Dr. Vasanthi, please go ahead.
Thank you very much, Dr. Neelam. And plan organized, it opened eyes in many ways. In addition to the medication safety, and we've had earlier safe surgery, the thing, I think inclusion of safe anesthesia and pre-surgical evaluation. Like recently, we also saw, WhatsApp post where, in the preoperative medication in the ward, which was given the rapid push of MSET, and the patient was shifted to OT, and on the table they found bradycardia, and then luckily they picked it up and reversed it. So about safe anesthesia, one. And then Suviraj John was talking about curriculum. It is already in existence in India in the undergraduate curriculum. Since most of us don't know, I think we have to raise awareness first among the faculty who are teaching that it is there and that it is to be implemented. And Dr. Tan's presentation was brilliant. Probably we can take a lead from there. How to make the media positive towards healthcare workers, and how to gain the public trust and commitment, and also in the question of generation of evidence. In India, for us, the major problem is generating evidence, analyzing, and creating protocols and following them. Implementation is the biggest hurdle in our country. So all in all, it was a wonderful experience, and I do hope that we will get all the links and the presentations on our mails, and it will be extremely useful. Thank you very much.
Thank you very much indeed, Dr. Vasanthi. So just want to respond to the question from Bhutan about the sort of involvement of a negative image which is created by media on patient safety, and how do we have somehow these investigations not seen as complaint but a process of learning. I think it's a very slow process, and it really requires a change in a mindset and safety culture at every organization level. Yes, there are many challenges in reporting on errors because they show human failure, and people don't want to accept human failure. So it requires sea change in our thinking, that how do we really learn from what has gone wrong in the system without any punitive action on those who are reporting. So a safety culture is absolutely fundamental to address your question, Dr. Neema, which you mentioned. So it's now actually 30 minutes over the time, and from the WHO headquarters side, I just want to thank all the speakers and participants for an excellent, excellent 2-day consultation. And my great appreciation to Dr. Aparna for her leadership. So I hand it over back to Dr. Aparna for her concluding remarks to close the meeting as well. Thank you.
I would like to thank Neelam and her team, and all these speakers and our dear participants from different member states for attending this and helping us out in organizing this informal consultation. Please feel free to reach to us. You can use our email IDs. You can send your request. As I said earlier, if there is a specific country-related request, please send it to our country office and they can forward it to us. We are always available to your request, and we will try to, address all of your requests in best possible ways. So from our side, this is all, and thank you very much to all of you. Thank you and namaste.
And a round of applause for SEARO leadership. Thank you very much, Aparna.
Thank you.
Bye for now.